Sí, exacto. Yo creo que hay otro código porque esto se sale directamente del Zoom. Lo conecté al Zoom.
En la pasión del castillo.
¿Sí?
Sí. ¿Cómo saliste de la pasión?
Bien. ¿Tú,
Sí.
tú no te has
No,
tomado?
se quedó.
116,75. Bien, ¿no?
Está bien. Parezco yo. No más.
Ah, sí. Ya me dicen mis hermanas que ahora ya, lo que antes veíamos que, oye, ya viste esta película, ya fuiste a pasear acá. No, ahora, oye, ¿tienes medicamento? ¿Tienes antihipertensivo? Yo me sobra, a mí me falta. Yo le dije, no puedo entrar. ¿Ya estás tú?
Sí, bien. Pongan la presentación, la principal, por favor.
¿Qué quiere?
Voy a bajar yo.
Vale, yo lo intenté.
Voy a enterrar. Sí, sí, pues no hay.
Primero contestaste. No, pues sí, ya.
No quise hacerlo. No, cuenta con- Ya, ya lo sé. ¿Una hora? No. Sí. 200, gracias. No, pues sí, una hora.
45 minutos. 45.
Gracias.
Ahora sí. No, porque es viernes. Si pueden, le hacemos un espacio aquí y le ponemos una computadora.
¿Qué tienes, negro?
¿Por qué fue acá?
Estás muy serio.
Oh, estoy concentrado. ¿Sí? Estoy concentrado.
Thank you, everyone. We will present you a brief cases that we will take surgery today and tomorrow for all the present. Dr. Aliyu from Panama is a resident of first grade. We'll present the cases.
Okay. Good morning, everyone. Thanks for the introduction, Dr. Ivan. I'm Dr. Joe, the first year resident of cardiothoracic surgery. We will present 6 cases. Today we will perform 4. Tomorrow we will perform 2 more cases. The first case We have the initial GFC, the case presentations. This is a 61-year-old female with the next height, weight, and body mass index. She has a history of rheumatic fever, diagnosed at 9 years old of age, who refers 3 months of worsenings, dyspnea, orthopnea, and edema of lower limbs. In the most important past medical history, also the inactive rheumatic heart disease that caused her the severe mitral valve regurgitation. She suffers of hypertension, dyslipidemia, hypothyroidism, and atrial fibrillation. In the workup of the patients, in the physical examinations, at the precordium, she has holosystolic murmur with axillary radiations. The rest of the physical exam is normal. And the medication, she's on enalapril, acenocumarol, bisoprolol, furosemide, atorvastatina, palifoxime, and levothyroxine for his chronic diseases. And the last laboratories is shown in the slide. Everything's normal. It has a chest radiography, seems normal also. And we performed her and TT echocardiogram and TE echocardiogram for the workup. The first is the transthoracic echocardiogram. The report is shown that she has a normal left ventricular size and no wall motion abnormalities with a left ventricle ejection fraction of 61%. Also have a severe mitral regurgitations with the pressure of the pulmonary artery systolic pressure of 24, and the left auricle is not dilated.
Juan Carlos, you have some commentary?
Sure. So here we are taking a look at the ethical for channel review. It's kind of interesting because in the setting of much about this fusion, what we would expect to see is fusion at the commissioners with the so-called, hockey stick appearance. And I am not seeing anything like that. We do not have pulmonary hypertension. I think that I would like to see better, the transesophageal echo, but I am not quite impressed so far about the severity of the mitral regurgitation. But again, I think that we're gonna get more information. I think that over here, the anterior leaflet looks a little bit more thickened and calcified, but I would like to see the transesophageal echo.
Okay.
So that we can really get a better assessment as to how much structural fusion we have and really how much structural disease we have. Because we are thinking in doing a repair. We just want to make sure that that's going to be possible. So far, I do not see any gross abnormalities that would preclude that. Maybe over here you can see a little bit more of the hockey sticking, but yeah, let's take a look at it.
Okay. Okay. Passing to the transesophageal echo, that echo shows these findings: a severe mitral regurgitation with incomplete coaptation of the mitral valve leaflets.
Okay, so when we go back to can we take a look at the previous image?
Okay.
The first of the T. Okay, it runs. It runs. Okay, all right, that's fine.
Sorry.
Let's go to the T.
TT. Okay. T.
Okay, so over here, the anterior leaflet and the posterior leaflet do not look very thick and calcified. Really, what gets my attention is that you're having a kind of a little bit eccentric jet. You're showing us over here a 3D reconstructions. I do not see any significant thickening or calcification of the aortic valve. I don't think that there is apical displacement. So I agree with the diagnosis that they're making. It looks to me, I mean, if we use the carpenter classification, that it would look more like a class one. Because I mean, it's just really incomplete cooptation. I do not see any evidence of excessive leaflet motion. I don't see any segment that is prolapsing or flail. There is no apical displacement. I think that I would like to go and take a look at the valve myself, in the OR, so that I can get a better assessment as to what is going on. But I don't know what you think, Mark.
Yeah, I think I agree with you that it doesn't appear to be leaflet abnormalities, especially not leaflet abnormalities typical of a rheumatic.
That's correct. I mean, this image is nice, for instance, to take a look at the commissures, and you do not see any evidence of really calcification or limitation in motion at the commissure level, and clearly there is no of the stick appearance there. So I think that if there's any issue, is issue in coaptation. It doesn't look like a rheumatic myelofibrosis. What do you think, Mark?
I think that the anterior leaflet's excursion is a little restricted, and I'm thinking the OR, you'll see
Correct.
shortened cords, they'll be a little on the thick side.
Correct.
And I also noticed there's no microstenosis, which is
Correct.
favorable. But I think that they're going to be thickened foreshortened cords.
Which will make a lot of sense, in terms of the mechanism of what happens, in rheumatic microvasculitis.
We also perform a coronary angiography, and there's no important findings. There's no atherosclerosis in epicardial coronary arteries.
Taking a look at these, what are your thoughts? I think that these are situations just like Dr. Bloom says, that you would just have to go and say, or maybe you would just have to go and release some of the fibrosis and cause some of these bodies that are living this discussion.
Yeah, I think etiology is important. History etiology, because it sort of gets you ready to start looking at the neck and think about what are the reasons that could be associated with the etiology. But if you look at that, and that's one of the very things that 3D is useful for preoperatively, very useful post-operatively. The commissures are not fused, so you have no acceleration flow in the ventricle, and the commissures aren't fused. So we can still have restriction and sort of arrested inflammatory disease, as Mark says, which is I put my first work on this. And you can also have lesser indentations that are abnormal, that are more sensitized to dilatation. But I think that these are all these kind of cases. If you took out the rheumatic history, you could look at that and say you have enough anterior leaflet, and you certainly have a central jet, which is typical of type 1 dysfunction, and leads to associating with the problem. And so your repairability valve should be extremely high. But you need a hook and then it's to do it correctly, plan it out. Correct.
Any other things that we're leaving out, Mark? Any other thoughts?
No, the main thing on is a pliable good anterior leaflet. If you have that, then Oxford has repairs of them.
And our surgical plan is to propose a mitral valve repair, try to do our mitral valve repair. We're gonna pass to the next patient. Okay. Thank you. Bye. Thank you. You're welcome.
¿Alguna pregunta? ¿Alguien acerca de la planeación del caso en cuestión? So, is there any other consideration on the surgical program? So, maybe it's I don't think so. Again, we will look at the practice of that a little more carefully up here and see if anything needs to be done to it or not. And then we'll like get some dialect already, so I think we'll discuss that a little bit here. The patient has a history of practice with fibrillation. So what is your all's current plan for that?
Going to the exclusion of the left auricle also in the
Maybe
after, yes. And in
Mace.
in my
priority.
Mhm.
Okay. I mean, I think you should look at, and you should better sell it if you can decide, I'm assuming what's a year, but I think you probably need to do that.
Are you surprised about the pulmonary pressures?
They're low. Better books.
no el otro la otra clase de su
Ok. Voy a poner otro radar.
el otro mental va
Son las dos primeras y
ok, vale lo va a pasar al caso vamos a pasar el mental va voy a pasar
sí, pasa.
okay.
An important comment comes that Mark just making. I mean, obviously, in good hands, you know, you will have experience in this in a qualitative way, you know, figure out your deal with severe religious conditions. But right now, really, there is a lot of emphasis in our guidelines to quantify. And I think that this is a situation where you have really two options. I mean, you can do it, you know, with some method. You can actually do it, you know, take more look at volumes and calculate what will be there will be some volume, there will be some tracking. So that you can really come up with a conclusion that you are truly in reality getting into your matter education. Now, the ideal moment to do it is not necessarily the operating group because you know information are able to be all changed. And especially, I mean, if you're dealing with a situation where the mechanism is part of your type 1, you know, you can have really a functional component, you know, that can be output in most of the calculations. So the ideal situation is to do that ahead of the surgery. Right now, we're putting a lot of emphasis in situations where if you're dealing, you know, with eccentric deaths or issues that are difficult to calculate, in using a multimodality approach and using CMR as a way to really calculate what is the relief and volume and the relief infractions in these situations where you're kind of on the fence and you're not sure whether the patient.
Okay,
Thank
you
you.
are agree, we will see the next mitral regurgitation case today.
Okay, passing to the next cases, the initial is CMM, the case presentation. This is a 58 years old male with a history of 1 year of worsenings of the symptoms of dyspnea and palpitations. On physical examinations, only have a low systolic murmur with axillary radiation. The rest of the physical exam is normal. She is on spironolactone and carvedilol, and the laboratories is in range of normality. She had that chest radiography. And she has also an TT echo and a TE echo. The TT echo shows these findings: a normal left ventricular size and no wall motion abnormalities with a left ventricular ejection fraction of 65%. Also report as a rare mitral regurgitations that is characterized by incomplete coaptation of mitral valve leaflets with a prolapse of P1 and P2, between P1 and P2, and the pressure of the pulmonary artery is 26 and have moderate dilatation of the left auricle.
Thank you.
Okay.
Looks like we with a type 2 mechanism I think that I agree with you guys that there is a prolapse of the posterior leaflet. I would like to see better
Let's see.
images with a TEE. I think that there is maybe a little bit of prolapse also of the anterior, but I think that it's posterior more so than anterior.
Yes, he has.
Now, there is a little bit of calcification of the mitral valvular apparatus, at least in the previous image.
Passing to the ECO2. Exactly. That report pattern for aminovaline, also the same severe mitral regurgitation that in this case shown, prolapse of between P1 and P2 and anterior of A2 and A3.
I think that there's a little bit of prolapse of the anterior as well, but
That's right.
the only posterior more
Is
so
the most
than
important.
anterior. I do not see a flail segment, at least based upon what you guys have shown us so far. Right, if the prolapse there, you can see it, but the jet is actually eccentric and more directed anteriorly, so it really speaks about the major contribution of the posterior leaflet. As you can see, the tip of the leaflet is still pointing towards the ventricle, so you do not see evidence of a flail, because if that is the case, then you would expect the tip of the segment to be pointing towards the atrium. And you're seeing a little bit of the left atrial appendage. I do not see any evidence of clot there.
Okay.
The function of the RP looks good. But it's a significant lesion. Any comments from the folks?
And the cardiac catheterization.
Sergio? Any comments on the echo?
Adequate leaflet issue, obviously an abnormal posterior leaflet. With two jets, one central, one eccentric. It generally means there, there will be more, but it should be very straightforward.
And the cardiac catheterization reveal no significant coronary artery disease. And our surgery proposal is the mitral valve repair and the closure of the patient foraminal valve. Okay.
Next case is.
The next case is also is from the aortic area. This is a patient with the initial COG. This is a male patient of 60 years old. The present history is of 6 months of Ornitz dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. The most important past medical history, he suffers of dyslipidemia and pre-diabetes, and the physical examination, protodiastolic murmur. The medication he's taken is losartan, and the labs is shown. This is the chest radiography. And we perform a transthoracic echocardiogram that shows a left ventricular dilatation, so with a left ventricular ejection fraction of 44%. Also, he shows an akinesia of the inferolateral and inferolateral and anterolateral wall. Also, severe aortic regurgitations with aortic annulus of 22 millimeters, and the pressure of the pulmonary artery of 31, and the dilated left auricle.
What do you think of the mechanism of the aortic regurgitation?
I think that you're having inverted coaptation. I think that you're having annular dilatation there. I think that there's I think that this is a situation where I would like to also inspect the valve. I think that there may be a little bit of thickening and calcification, but I think that probably this is a situation. Again, I'm always very careful with my words, but I think that this is a situation where you take a look, how much dilation you're having on the aortic root. I think that this is a situation where most likely you will be able to resustain the valve. But I would like to take a look at it. Any comments, Ismael?
Yeah, I think the mechanism is definitely dilatation of the ventricular junction. I'd be surprised if the annulus was really 22 millimeters. I think the annulus probably should be bigger than that. It's rare to have such a big root aneurysm and no annular dilatation. It will happen occasionally, but usually in older patients. At age 60, usually there's some degree of annular aortic ectasia, which in some ways is favorable in terms of trying to preserve the valve, because then you can really reduce the size of the annulus, increase leaflet coaptation. On the long axis, you see the thickening of towards the 3X. This is rolling of the leaflets back. It shortens the length of the leaflets, and it plants a bit of doubt in terms of the ability to preserve the valve, not to have a perfect result in the operating room, but more so in terms of having a durable result. So like all of these patients, we always tell them we have to make sure that it's doable, but you also have to make sure that it's durable. And if you have a competent valve, but barely any effective height and barely any length of coaptation, these patients are going to be back within 1-5 years, something like that. And it's not a win for the patient, it's not a win for the surgeon. And so you see that too is the one that is most concerning, because that hyper-echogenicity that you see in the tip is thickening and rolling back of the leaflet. That's not a good characteristic for a leaflet that you want to preserve. And at age 60, with long-standing AI like this patient has, his ventricle is dilated, the EF is not great, so you know that this has been ongoing for a long time. So these changes are very chronic on the leaflets. And the leaflets are more fibrosed, and it reduces the ability to preserve. If the patient is 30 years old, you'll push to preserve the valve. 60, you have to think, what's the benefit of preserving an imperfect valve versus replacing with an adequately sized bioprosthetic valve. So that would be my interpretation of the echo for the family.
I mean, if you take a look over here, it's kind of interesting, as Ismael mentions, the way that the valve coapts. If you take a look at the long axis at the tip of the leaflet, you see thickening and calcification. Again, I would like to take a better look. Now, the other thing that gets my attention, in contrast to case number 1, is that over here we are really having apical displacement. We're having a regional motion. If you take a look at that, inferior lateral wall is completely eliminated. So I would like to make sure it doesn't seem to be that you have significant MR there that needs to be addressed. There is also a peripheral diffusion that has not been commented out.
Okay.
Marco,
Yes.
I think that it doesn't look like it's just due to annular sinus junction dilation, because the leaflets appear to be relatively normal position. I agree that the leaflet over to the right, which is probably not coronary, I can't tell, but is restricted, or is probably fibrotic pulled back, in which case probably won't be able to get it repaired out. And with ejection fraction of 44%, we don't want to necessarily try to do a repair that's unlikely to work, and then we have to go back and replace it.
That's what I was gonna say. It's just, my first impression is that's a sick one.
Okay. Previous to pass to the seat. Okay.
Well, I think 85 kilograms. If we're doing a root replacement, I think we're gonna be able to get a bigger size. Um, If we didn't have to do the root replacement, if it was just an ascending replacement, then yes, I think we do an annual enlargement. But this gentleman's not small. At 21 or 23, that would be small for him.
What kind of, I imagine that you guys have a CT scan.
Yeah, we have.
What kind of information do you have with the root and the ascending order?
We will show these at the images, but the exact dimension is. Sí, sí, ahí lo tengo. Our ascending aorta is. Ascending. At the CT scan, let me say.
We have a CT scan.
See, we have a CT scan and also a cardiac catheterization. We are to answer that the annulus is 28 and the CT scan, the ascending aorta is 45 and the sinotubular junction is 55. The valsalval sinus is 52 millimeters.
Can we take a look?
Okay, yes. Okay. We perform a coronary angiography. There's no significant coronary artery disease.
Right, I'll just make a comment for the residents in the room. It's very important to look at the angiogram in these patients, because when they have severe aortic regurgitation like this, especially if your cardiac treatment strategy is anti-grade selective, you really have to look at the length of your line. Oftentimes it will be very short, or you sometimes even have a double narrow. But you really need to know, because if you put that cannula in there, then you're selecting the LAD or the circumflex. Especially in a case like this, where you have to have perfect protection, you can have a lot of trouble coming out by. So pay a lot of attention to the coronaries on the angiogram if you have it, and importantly on the CT scan as well.
Okay, thanks.
So this left leg here is long enough, so we know that if you use the selective cardiac cannula, you don't have to worry too much. It's going to distribute everywhere.
Okay. Passing to the CT. The aortic annulus is 28, and the aortic the dilation is of 55 millimeters. Of the tubular junction, the most dilated portion. Seems to be the.
You have images of the arch, just to see whether we do an open this or
In this presentation.
in the
Sí, lo que tengo notado, pero lo más que tal, son diciendo
This is a bento.
el arco de
One of my concerns, what we do
es que si se va a
you don't even have to think about it. Give me 1 hour, we'll have. Yeah, I wouldn't get too fancy. Like Mark said, the veteran is sick.
Do you have any genetic testing in this patient or not?
At the physical examination, there's no physical findings of Marfanos or collagenopathies, and there no family history of dissection.
And what about in the same scenario in the younger patient? Do you try to bulbous per procedure?
I think the one thing that will dictate whether yes or no is the leaflets. if the cuts are, if you have like geometric height and they're pliable and there's no calcium, there are no big fenestrations, and there's no retraction or fibrosis, then it's a very good candidate. And then the more you have of these features on the leaflets, the less of a candidate it is, and maybe the durability may be impaired. But if the patient is very young, you will still go ahead and consider preserving the valve because, you know, tissue valve is not great and mechanical valve is not great at age 30 or 40 or even 50. Especially if the ventricle is okay and you can afford to, you know, try to repair it and then come off bypass, see whether you're happy or not. If you're not, you'll replace it. But in a case like this, you have to be, the decision has to be made pretty quickly. I mean, you can take 5-10 minutes, you know, to look at the valve, but I think the decision here is already made. But the younger the person, I agree, the more you want to try to keep the valve, because that's where preserving the valve really has an impact on the patient as well.
Okay.
I think that the point that everything automatics is a good one. I mean, we have put all of the puzzle together, right? And this is somebody that has, you know, low motion on the body with a sick ventricle. You don't want to mess a whole lot with this patient. You want to go in, as Dave mentioned, do your thing and come out, make sure that you have a short time and that you fix the patient good. I think that if you take a look at what we have seen, you have thickening calcification of these leaflets in the short axis, it looks retractile. I think that the possibility of yes, leaving is pretty low. But I think the point is well made that you gotta think about it, you know, especially if you have in front of you a young patient. And in this particular case, I think that the interest in going and keeping this valve is close to zero. Right? Yes.
I think it's going to be an open business. Yeah, this one. But open, yeah, it seems like by the way that you look at papers not important, you know, it seems like you don't have to ready to circulate the sky. Maybe.
For cannulation for these cases, just to avoid a circular arrest, because you want to keep the bypass time short, we tend to cannulate from the distal arch. So that the cannula is very far, you can really dissect all the aorta up to the innominate and clamp very, very distally. So that then when you're even if it's 4.3 or something, you can still include this in your anastomosis. And it's probably gonna be okay. He's at age 60, he's gonna live maybe another with a ventricle like this, his life expectancy is no more than 15 years, let's say. Unlikely that this aortic arch will dilate to, you know, go over 55 millimeters or causing that much trouble. So it becomes a balance of you want to be absolutely perfect and remove everything that starts with a 4 centimeter or accept leaving just a 4.1 or something very distal aorta and just try to include it. But the important thing is if you cannulate the ascending aorta and then you're clamping below it and you're sewing below that, you're leaving a good 2 centimeters of distal. So the cannulation strategy is very important. And that you have to really dissect, remove the pericardial from the surface of the aorta and then cannulating the arch in order to allow you to clamp that.
Okay.
This is not the normal, but if you see a very small annulus, what technique of how to handle enlargement you prefer?
Again, in my opinion, in a case like this, he's not going to die from patient prosthesis mismatch. He's going to die from a long operation where you try to do things. So if you have the stentless valve, the freestyle, that would be my approach if the annulus was 21. So do ventral, but use a stentless valve. Hemodynamics will be perfect. And from a durability standpoint, it's going to outlive him probably. If you don't have the freestyle and you only have stented valves, and 21 is what fits, I think it's fine. Honestly, I think it's fine. I wouldn't go too crazy in a patient like this. We have to again balance what we're trying to achieve here. And this patient is not going to live till he's 85. Yeah, I mean that's my take on it.
Yeah, no, I agree.
Annular enlargement.
If it's with a root replacement, I don't think we'll have any problem with size. If we did not replace the root and he had a 21, that might be a little small for him. The root enlargement with a NICS technique is fairly quick to do. It only adds another 5 to 10 minutes, really. So you can do a NICS procedure to get in a 23 or 25 valve in this gentleman, if we didn't need to replace the roof. But replacing the roof will be able to get in a good size.
Okay. Do those findings we propose a replacement of the aortic root by a ventral de bono procedure by biological prosthetic valve? The next case.
I just will say, all the years you were living in mortality down, since that's 35 years. I've never seen the case presented where we hurt the patient by putting the size 21, but I've seen lots of cases where we hurt the patient by trying to get to 25. I just think this is very different than a lot of patients that you take care of in the aortic root space. This patient needs whatever the quickest, fastest thing is that's going to work once, like Mark said, is you got one good shot at this.
The other lesson that we learned when we worked on the clinic by my former colleagues is that at least when I did fellowship, our deeper medication was always told to me as kind of as lesion that was forgiving, that in the moment that you will operate the patient, the ventricle will shrink again and the ejection fraction will get better. When you take a look at very sensitive indicators of cardiac performance, like blood and longitudinal strain, with the help of the clinical team, we have learned that that's not the case. That the strain, once it has become abnormal, it stays abnormal. And there is a price to pay in terms of mortality if your DLS is less negative than -90. So in this particular case, you have wide open AI by all of the mechanisms that we have mentioned. On top of that, you have a ventricle that has coronary artery disease and is sick. Don't you think, that in the moment that you replace the valve, the ventricle is going to perk up and you're going to go into the 50s? The ventricle is sick for 2 minutes. You're having wide open AI and you have to not to decide, not able to do in Darby down, it's not trying to go for perfection. Sometimes, perfection is the enemy of practicality, and we end up learning that the hard way when we review cases in M&M.
And if you find a double garble coronary stent, how do you perform the cardioplegia?
Well, you can either just use retrograde cardioplegia, but if you want to use selective antigrade, I take smaller cannulas and I selectively cannulate the LSD in the circumflex. So you take a 4 millimeter cannula and put it in the LSD, 4 millimeter in the circumflex, and you put another one in the right formula. This way, you're absolutely sure that every cell is getting cardioplegia.
Okay. El siguiente es de los hechos. Okay. Passing to the next patients, this is a 64 years old male with a history since October of 2023 of history of angina and dyspnea until he is diagnosed until May 2024 with severe aortic stenosis. And in January of 2025 of this year, he has an episode of syncope. There is no past medical history at the physical examinations. When he's admitted to the emergency room, he had a systolic murmur in the aortic area radiating to the neck. He's on enalapril, metformin, spironolactone, furosemide, allopurinol, and atorvastatin. And the last laboratories it show with a pro-BNP of 4,600, and the rest of the laboratories seems normal. This is the X-ray of the patients. And we performed at the urgency room a angio-CT because of the episode of syncope, and it's shown that he has a bicuspid aortic valve Siever's wand with fusion of the left and the right coronary sign commissures with thickening and calcification of the leaflet with a valvular aortic valve area of 0.6. And there's no epicardia, there is epicardial coronary arteries with mild atherosclerosis disease. We also perform a TT and TE echocardiogram. The TT echocardiogram shows a left ventricular ejection fraction of 34% with also a systolic dysfunction of the right ventricle, biventricular dysfunction, and a severe aortic stenosis and moderate regurgitations with double injury of the aortic valve with aortic valve area of 0.4 and a maximum velocity of 4.7 and medium gradient of 60. Also reports moderate mitral regurgitations, a mild tricuspid regurgitations, and a pressure of the pulmonary artery of 47 and a dilated left auricle.
It means a bad.
Y bueno, era hacerle plastiómetro. Sí.
How do you tend to treat the orientation like this? What can you do there?
No, we did, we would. Yeah, this isn't down, this is very
Very
But
Yeah. Maybe these two guys are gonna be next to each other, and you know, this way, they're going to wide.
But these cases I find are very unpredictable. Sometimes they really screw up. Because the valve looks very, 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 it's like a rock. And some you just replace the valve and they wake up again. And it really depends on how they look and how functional they are and how robust. If the patient is walking around and doing all this stuff, they usually
do well.
they just do well, you know, and then when you see them in 6 months or 12 months after recovery. The good news is the right ventricle, actually, I'm not thinking it's being used now. It doesn't look really, really very.
Agree. I was gonna make that point. I feel I'm very uncomfortable with this case. I mean, what I'm saying is, again, I would like to go and recalculate the ejection fraction to the naked eye. It looks kind of like a generous 34. The point is well made, you know, that you are having a gradient of 60 millimeters of mercury, so you can get things better. But I think that you have a component of a mitral regurgitation, and I dislike the fact that we're having pulmonary hypertension in this particular case. And quite frankly, I am worried about the function of the right ventricle. This is a situation where I would like to get a more quantitative assessment, calculating the RPS prime, calculating the TAPSI, because then the whole thing changes, you know. Now, in this particular case, it's a bicuspid aortic valve, so the possibility of going with a percutaneous approach is less appealing, but you gotta be ready, you gotta know what is that you're dealing with. We do not have evidence of coronary aneurisms here, right?
We only have the NGCT that is mild.
So in contrast to what I said about aortic regurgitation, what we have seen, and it was already mentioned, is that if all what this ventricle has is just increase in impedance and increase in afterload, the ventricle is gonna wake up, you know, in the setting of AS. You do not do medicine. There are situations where you can have some fibrosis in the setting of protracted AS, and you will be able to see that, you know, with low longitudinal strain or, with an MRI. But, again, this is not a straightforward case. I think that we need to take a look at. How do you feel about it? I mean, it's speechless, you know?
No, he's a very, very sick
Yes,
patient and extremely symmetrical.
yes.
And there's an element of unpredictability, and like Dr. Andrew was discussing, this is one patient that we would admit prior to surgery, at least a couple of days, optimize, try to get, put them on this and that, optimize the volume of, because every little detail will count.
Like, when was this, let's just make sure we're doing the right things. This patient, when was the cap?
No le hicieron
Was that a few days ago, or a few months ago?
2 months.
2 months. The
Okay, guys, please be clear, you have no idea where this patient is today. So this is the sort of patient that we admit for several days or three. We usually would start them on lower and gently dilates them. Do a right part cap, not the left again, a right part cap 3 or 4 days before, make sure we're optimized. I agree with Ishmael. Usually, many times, you're surprised at how well these patients do. You have to have everything else ready. You have to make sure you have a plan. You've done it. He's had a CT, I'm assuming, on his vascular system. Yes, you gotta make sure it's, you got a cannulation plan for a blue pump. We really, ideally, would have the right heart pressures before surgery, and I think you gotta assume the other problem is incomplete therapy, because he does have moderate regurgitation, his leaflets are dead, he's frightening, sick. Ideally, this is the sort of patient you can do. You can ideally do a patient like this with about an hour and 15 minutes of ischemic time. You have to be very organized to do that. And generally, that's what we do in our program is mitral and tricuspid first, close those atria, and then do the and try and do that in 40 minutes. And then you have 30 or 40 minutes to do ADR. It's not that quick because it's not that small. There's a lot of calcium, so it's going to take. Even if the surgeon's another 30 or 40 minutes, you say, yeah, that's the ideal, that's the best possible. This can easily drag into the second or 2.5 hours. You might be sort of see a lot of experience. Skip the tricuspid, because that's, again, you don't have time to do a lot. So this is a real, and then your intensive care unit, hope for the best, plan for the worst. You guys have nitric oxide. I don't know what you have. You have nitric oxide. Do you have any way to lower
Nitric oxide we don't have, but the rest of the medications we have a close communication. Come. I see.
I think that the question is whether this guy is really ready today. And you can make those assessments in the OR too by putting a line in to see what the pressures are. But I will tell you that we have patients like this come, and once a month we put someone like this to sleep, repeat the echo with a squat, and you cancel the case. Unless it's optimized.
Okay.
You go back upstairs. There's no chance that we just push forward because you're on an OR table. Because again, remember, he's supposed to go home. It's not like, the SDS says 5% or 6%. Doesn't make any difference. That means that we're supposed to be organized and really good, and that's 800 places. And send these people home. If you should get it to 1 or 2%, which means you have to leave every stone look under. Trying to optimize things, but he's very sick.
Yeah, we saw him in few months ago.
Yes.
We choose the case, but he suddenly presented the syncope, and he is still acute heart failure.
He's in acute heart failure. That's what I mean. So this is someone where it's tricky. This is a big problem. This is, you gotta pay very close attention to, or you can get in trouble. Really quick.
What was the plan for the patient?
Okay.
What
We
was-
also have a T echocardiogram. Answering the question, he previous of depression illness, he's functional. He's admitted for the episode of syncope, but that in the hospital he's been for at least 2 weeks. Optimized the TAPSI is 20, and the right ventricle shortening fraction is 27%. And this is the T echo. It shows left ventricle not dilated with systolic function preserved. The mitral valve show a posterior mitral valve with myxomatous appearance, mobility, and leading to moderate regurgitations. And the aortic valve, that T report a tricuspid valve that is calcified and shows a severe stenosis and mild regurgitation.
I mean, over here, they are not showing the entire LV, but I think that the functioning
No, it's not.
as we had discussed before, at the least moderate to severe, if not worse. Now, if you take a look at the functioning of the right ventricle, the functioning of that right ventricle is decreased. I think that a point that is well made is that when you're taking a look at the functioning of the right ventricle, it has two components, the longitudinal component
And
and the circumferential component. You do not want to be misled out of the fact that over here your indicators of longitudinal functional are normal. You take a look and you mentioned the fractional shortening is reduced. And if you take a look, this is a ventricle that to the naked eye, the right ventricle is decreasing function. This is a ventricle that is going to get you in trouble. I say it for me. Mark will tell you on me from our party meetings. As the functioning of the right ventricle will directly operate. You know, this is a case where you have a time bomb there. This is a patient that, yes, is admitted with syncope because of severe AS. We know that this is what happens, but there's more, you know, into the complexity. This is not just a severe AS ventricle. You know, sometimes you can have situations where the pulmonary pressures are up, happens in 25% of the cases, but already when we have an increase in pulmonary pressures, and you also have mitral valve disease, you have RV dysfunction, you have a patient that is in failure, problem.
The other thing is, you guys do remember that too. Your PA pressures are elevated, so I don't want your right ventricle not working so well. Your PA pressures aren't so elevated. If your PA pressure is 47, around that 50 systolic, there is no fine hand physiology here. Maybe you can't count on passive flow. So I feel much better about these kind of cases when the PA pressures aren't that elevated. But with an elevated PA pressure, right now, if it's a little sicker, you really can end up with a, you know, buttons on the state, just from the right side. And the problem is, you get anybody out of the OR without an adequate days. But what you can't do is prevent, you know, a pararenal syndrome if you're seeing these elevated. And you take on fluid during surgery. So that's why the other thing you have to really have in the back of your mind here is renal replacement therapy. How are we going to take fluid off? So like in centers like ours, we have the ability to do ultrafiltration, you know, point of care. So we can start ultrafiltration that night, 24/7, just by person. So that's the problem, is that you know, to really get good results here, you got to have a lot of tools. Very good question. Jamie be thinking very carefully about this patient. And whether we have to have agreement for everybody that this is doable. Now, in the age of TAPR, it's interesting because, you know, in the old days, we used to put cases like this sometimes in trying to do a full galloplasty, knowing that we would operate in a few months. Just to see if leading the construction made them a little bit better. This is the kind of patient, if you had a TAPR program, you could easily talk about. Of course, my experience with structural disease, they never were a few people that actually might really benefit from it. They're all smooth. They just want to think they're gonna help you people that are super curated, like, you have to talk them into it. This is not a case. We definitely had to see this patient before this.
I think that immediate recommendation will go for our website get accurate assessment of where you are in terms of pressures. And yes, go, I mean, I don't know if you guys have over here a pulmonary hypertension team that can help, decrease the pressures, but I think that taking the patient, with pulmonary pressures close to feet is not a good idea.
No, it's a good drug, and it's preoperative liver whether you really do know everything. And then that also gives you the chance to see whether you like the particular function it's on, which makes you feel better.
But I think that the point to be learned is that rushing these cases is not a good idea. You just gotta take your time, take the patient to the cath lab, optimize, and bringing down the pulmonary pressure changes everything in terms of the management of this patient during and after surgery.
Yes. Unfortunately, we choose not for the biggest procedure.
Exactly. We are very ambitious. Thanks for the comments, doctors. But we propose Ross procedure with a mitral valve plastic.
This is not because we're here. This is not how they go anywhere. And I don't think I would consider a Ross procedure in this patient for a number of reasons. One, because of everything that we just saw. Two, you want to consider a Ross if you think that the patient would benefit from the Ross versus an easier alternative, which is like the conventional valve. This patient doesn't have a life expectancy of 15 years or more. He's already 64 to start with, but a very sick 64. So he's not going to live to be 75. So will the Ross do anything to help with survival, or hemodynamics will be maybe better? But all things considered, that for the longer operation, you'll pay the price for it. And if you want to see him a year from now, he has to be alive a week from now. And you do the Ross, you're probably increasing his surgical risk by a real margin. So I think the operation he needs is an AVR plus minus the other valves. I don't know. I think my approach would be an expeditious AVR. I think the mitral will get better by relieving the obstruction, and you'll go from moderate to maybe mild, and hope that you can get him in and out quickly. If you want to dive into the mitral tricuspid work, then you start to. I would just simply go in, remove that valve, do it as quick an AVR as you can, and try to get up there alive. And then if the patient is functional as he stands with the anatomy he has, if you just replace that valve, he's going to be very functional for the 5 years that he has left to live. So that would be my take on this patient.
I'll tell you about a Ross. You guys remember this. So Ishmael does 100 a year, 100 Ross procedures, which means there's no learning curve. The whole group does 100 Rosses a year, and I was laughing because we do a lot of these things together, a lot. Mitral and Ross procedures, and it's funny because I chuckled with him a while back, and I said, "So let me get this straight. Like it takes your group, like you doing everything, a little over 2 hours to do a Ross, like 210. So it's like that's as good as it gets, unless you're going to start sort of trying to cut corners or do things like you can make it, you can do anything, but it's a 2-hour procedure. You're never going to put this patient through an elective 2-hour procedure. Not unless you want to have a lot of tissue boxes around it. I recommend some of this fast as you can. I mean, the mitral is interesting because I get a little nervous about moderate MR with heart failure. Yeah, because the patient does have a history of heart failure, so in an ideal circumstance, you do it. But I think you can make that decision in the OR too. I wouldn't agree to any, because sometimes you take this patient to the OR, the atrium's acting not so big, it's not really easy exposure. You've got you're not even thinking about it for this day. And other times, that atrium is bulging between, pushing the right atrium forward and you're sort of screaming. I have severe analysis of the time. And I think problem if you do it, so you should be flexible. Not just, I'm gonna do one thing or another. These big medications, you can't have some. Everybody, we all start with our bias or our plan, but you gotta have a quality decision making.
Okay.
Real big case.
Big case, yes, sir.
Mark, it's a question for you. What, if at all, are the scenarios where clinic from the labs are doing towers doing bicuspid aortic valves?
The beginning of the bicuspid valve tower discussion is no. So we begin with no. Then if the patient is very sick, perhaps someone like this, either a sick heart or other serious comorbidities, then we'll talk about it. But in the beginning, the discussions know about once a year, we have an angular rupture from bicuspid valve, which is almost uniformly fatal. And then they first get the pulmonary leaks, the coronary issues with so right now, we begin with no. What do you guys think?
I think the approach is also no, but then there's secret, that we don't have like the perfect,
Yeah, we're not perfect.
yeah, there's no perfect sort of control. A patient like this is one that I'd be open-minded to discuss also, because, once they do all the imaging, and if the rapid is not too calcified, and the LVOT is not too bad, and the angles of this and that, and they don't think they'll end up with PDL, I would consider a TAVI in this guy. On the other hand, you don't want to do a TAVI and end up with a paravalvular leak and a pacemaker and lose your ventricular synchronicity, etc. Because all of these things will be confounded in someone whose both ventricles are so bad.
Yeah.
So you want to have if you're going to replace, you don't want to have any residual PBL, you don't want to have a pacemaker. So or even a left buckle can be very detrimental to the ventricle. So I would consider it with the family team, but my bias would still be if the guy is like you described, he's functional and he's going about his day-to-day life to some extent. I think usually these patients manage to go through the surgery. They've told you they have physiological reserve. You just take that obstruction out, but you have to be very efficient in the OR, and you don't want to get bogged down with trying to be absolutely perfect with every single valve and every single lesion. We'll just go for the one thing that's killing it right now, which is the aortic valve.
What size sirens you got there?
Yes.
We got 22.
Just 22.
Okay.
Yeah.
He weighs about 140 pounds.
Yeah.
Exactly. There's no one as much.
You would have got this as a target comparison, you want the.
Yeah, so Texas part, we have had our experience, in terms of taking these patients to be done continuously. I think that just like we mentioned, we judge comes from experience, and experience comes from bad judgment, so we have made our mistakes. Right now, we have created kind of like thresholds. We are particularly concerned when we have higher scores north of 5,000, because we know that this is when you have an excessive amount of calcium that really, the potential for paravalvular leaks. We are using simulations in these type of cases. So if we have a bicuspid valve like this one, and if we were to consider it, then we will ask for the simulation that will tell us what is the risk that we have of annular rupture, what is the risk that we have of compromise the coronary arteries, and what is the risk that we have of paravalvular leak. Now, I have to say that if the simulation comes okay, reassuring them that we are not going to have issues in any of these three areas, we have proceeded with success in this case. But again, we are very wary of these type of situations where the patient comes, just like we were discussing yesterday, the dinner table telling us, I do not want surgery. I have done my search in the internet. I 20 minutes, and then they think that they're experts, and I want the tower. And then we know better. I mean, the situation tells us that we're going to approach the ambulance we have, or that you are going to have a bad part of your league, you know, that we're going to compromise the variables. And so, you know,
That's the last thing.
the last information. We like them, again, I mean, usually we go pushback, from the hospital. Because it's expensive, it's like $1,100. I think that right now it has decreased, and it's billable, but it was decreasing the bottom line for the hospital. So at the beginning, we had to fight aggressively, but it has really decreased the number of complications. I mean, we had kind of a run where we were stumbling into these complications, even with experts taking a look at this at the time. And right now with the last, I mean, ruptures or biparticular leaks or compromises the coronavirus are out.
And Dr. Gino, the treatment clinic, you would put up a intuitive valve or a personal valve in this event, or just to getting it out to save some time, or just.
No, we probably just do a very standard bypass.
What about you, John?
No, I never, I mean, I should say that, but we actually don't even carry those 600,000, but I don't think they're very good value. The only scenario is if you're redoing the very calcified homograph, I think that it's reasonable to do that. But outside of that, I think we should be using the situation. To me, they combine the worst of both worlds. Open surgery with bypass and ischemic time, and higher PDL and higher pacemakers, worthy of the nice other times. So you're gonna open and the rest of the heart, you may as well just take an extra 15 million. That's my thinking.
We'll keep it simple.
Yeah.
It's standard.
Use the keys approach.
Well, because they do it, the reason I brought it is because, what happened to us, you go there, put an intuitive valve, and then you have a valve leak, and then you just got to cross kind take the valve out, and then you ended up with the same problem. That's what I was saying.
Okay. The next two cases is scheduled for tomorrow. The case is number 5. The case presentation is a 66-year-old male with a past medical history of corrected aortic coarctation, hypertension, and permanent atrial fibrillation. And the physical examination, there's no pathological findings, and he's on acenocumarol, perindopril, indapamide, atorvastatin. And the laboratories is shown with shows that also suffers of pre-diabetes. This is the chest X-ray. And this is the transthoracic echocardiogram. The findings reports asystolic dysfunction of the left ventricle with an ejection fraction of 41%. Also bicuspid aortic valve type Sieverts type 1 with mild regurgitations. The pressure of the pulmonary artery is 24. And the measures of the ascending aorta, the annulus of the aorta, the annulus is 1.9 centimeters. The valve sinus is 4.8. The sinutubular ejection is 4.3, and the ascending aorta 5.2 centimeters.
Juan Carlos, what do you think about that aortic valve right there? It doesn't seem to open very well.
No,
They don't enter a gradient.
Correct. Well, I mean, bicuspid aortic valve, as it was mentioned before, but the valve looks abnormal. I mean, you have evidence of thickening, calcification, not so much over here, but in the previous images, sinuses of Valsalva that are increased, ascending aorta, aneurysm. Take a look at how normal the valve is. Again, I don't know where it's not solid.
Yeah, I'm just not quite clear why the ventricle is so bad. It's not right. Because there's no real, but yeah, the valve doesn't look normal.
No.
Any explanation for the ventricular dysfunction or no coronary disease? No.
What's 41? The ventricle.
Long-standing hypertension?
Yes, large hypertension.
Lo tiene acá. Se lo tiene blanco.
That biopsy cost to be used now? No, it looks like that's yeah. You know, sometimes with these, because it's very symmetrical commissures, almost 160, 170. When the aneurysm is very large in the roots, it stretches the valve up to the extent that on the short axis, it looks like it's barely opening. And when you reduce the dimensions, it tends to look better, but I do agree that it looks a little thickened in the other views.
Okay. Uh,
Much more in the long axis view, yeah, very short axis. Yeah.
And the CT scan shows an epicardial coronary arteries without significant coronary lesions and the findings of a bicuspid aortic valve.
He's the guy with the patient, right?
Yes, that's correct.
How old is he?
66 years old.
Is there a gradient, approach gradient?
There's no, there's no findings in
What are the
the
blood pressures now?
let me check that.
I think that's like.
Can you slow that? Yeah, I just want to show that left vein, the left corner, that goes back to the point we were just making, it's just so important. Have to move forward now, go towards where the left coronary takes off. Again, in planning for your strategy for, if you're not using retrograde and you're using selective, when you do the root, see how it's double barrel, move back. There, like. See the LAD and the circle move back just a little.
Dejé como estaba en video.
There. And so you have that little knob, but it's not a left vein, and it just takes off. So you have to be very, very careful when you see that. That tells you I'm gonna have to give it in separately to the LAD and the circumflex if you want to protect this one properly and come off bypass without issues.
I want to go back to the point that Vicente was asking. Do we know what has been the control of the blood pressure? Because, I mean, again, we're dealing with a signal control, and I just want to make sure we have a history of coarctation. You're telling me that the coarctation is resolved, but I mean, is this patient somebody that has uncontrolled blood pressure, or is this hypertensive heart disease?
This is a for okay.
Because of that.
Okay.
I don't want
One second.
the blood pressure now.
Okay. And en la aprilación humoral, pero en la aprilación en la también.
You can open this.
Sí.
This one,
Ese es el
because
de
especially when patients who have a coarctation and bicuspid coarctation is a high risk feature, even if it was repaired and even if you don't have any residual gradient, it's a high risk feature for these aortas. So because you could also argue if you didn't have the coarctation and 66 and the root is 4.8. And if ventricle is a bit sick and this and that, you just do an ABR and ascending, you have to do a red call. But I think in this case, you want to replace the aorta from the root all the way up.
Yes.
And
Yes.
This is not the appearance of the gastric ascending ectasia that you will get because of the way that the flow goes, the bicuspid aortic valve. This is a situation where I think that you have connective tissue that is abnormal. The root is dilated, the nodular functions are effaced.
Rotation.
You basically got us, like the sickest pocket. Exists or
The experts. The experts.
No, this is exactly like the cases that we want to discuss. All cases, and we can just think about the cases together.
And what's happening here is as important as what happens in the operating room.
Yes.
Exactly. So two different.
Skip this discussion and go straight to the operating room, there'll be a lot of problems.
Yes.
So this is really, really important.
Yes. Thank you. And we propose ventral de bono procedure plus an MER. Yes.
Yeah.
Okay. And the last patients, case number 6, is a 63 years old female of history of 5 years of chest pain triggered by effort and 2 years of episodes of fainting associated with palpitations. There is none past medical history and the physical examinations. The murmur that is in the aortic area that is radiating to the suprasternal notch, and she's on aspirin, bisoprolol, spironolactona, simvastatin, ezetimibe, venlafaxine, and the rest of the laboratories is normal. This is the chest X-ray. A little bit, yes. And this is the first the study. So we perform a MRI heart perfusions study that reports a left ventricle with the diameter of the diastolics of 37 and the systolics diameter of 25 millimeters, and also report an asymmetric obstructive septal hypertrophy myocardopathy due to the anterior systolic motion of the mitral valve. And the function of the left ventricle is 68%, and the right ventricle also is normal with a function of 56%.
Well, I mean, beautifully, you see, the asymmetric septal hypertrophy that you have in the MRI is showing it beautifully, and you can see how you have systolic and anterior motion. But I mean, really, what you have is also septal contact with the most anteriorly located papillary muscle. I have a question for Mark. If there is something that I learned working with you guys there, it's the importance of taking a look at the position of the papillary muscles when you're trying to address pathology in the setting of hypertrophic cardiomyopathy. Do you see anything that concerns you over here in terms of the anatomy of the papillary muscles that would be worth correcting? Because what we have seen when I was in the clinic right now back, that takes us part in our situations where the abnormalities of the papillary muscles are completely neglected, and they can either do a myectomy or they can use a septal ablation. But if you are not addressing, the structural pathology that you have in the mitral valve, then you're going to continue having the systolic anterior motion, and you have not had the patient whatsoever. So do you see anything over here beyond?
I don't, but I'm better at looking at.
Taking a look at the echo with
And
exactly.
also mixed Madeira would be the one who would answer that question.
Yes.
With the best answer. It's interesting that the male for the Hartzell Schaff and the team there would say, you never have to worry about the papillary muscles. And at least half of our cases, Madeira will reposition them.
Correct.
What's your opinion?
I don't know what represented, but
Bring it together, I guess.
Correct. So in this particular case, let it play.
Sorry. See if I'm blue.
So what you see over here is the two papillary muscles kind of like this, and see them? And then as a result of that, it really favors, the anterior migration. So what he does is he will actually bring them together, interfering with the ability of this papillary muscle to travel anterior.
Yeah.
I do this, in a very humble way, but our experience has been that I have seen cases where you end up dealing with a still physiology of obstruction despite the fact that there is a myectomy. And so I respectfully disagree with the major clinical approach.
Yeah, and the papillary muscle repositioning is a little bit more of a feeling type operation, but in general, when it looks like Spinner will do is just with vegetative sutures, really close together.
Yeah, and sometimes you have also cords that will hold the papillary muscles towards the septum that you have to cut the center. And when you have mid-ventricular obstruction like this, your myectomy has to be very, very deep in the vessel.
Yes.
So the echo is very, and this MRI here is very helpful. You have to measure the distance from the plane of the annulus to where the knuckle, to where the thickening, and see how many centimeters you have, what the thickness of that is, so that you start planning. I need to go 4 or even sometimes 5 centimeters down into the ventricle. I need to be 1.5 centimeters thick And so the knife and the thickness of the knife and the length of the knife will tell you a little bit how far and how deep you're going. And as you shave, you start to see better inside where in a case like this, you have to go to make sure that you don't have any thickening across from the papillary muscle. Because like Juan Carlos was saying, you'll remove the obstruction at the top, but you'll stay with mid-ventricular obstruction. You haven't really helped the patient. The other thing for mid-ventricular obstructions like these is to look on this view at the apex, because occasionally you'll have apical aneurysms. And that really tells you that there's very severe obstruction. In some of these cases, you actually have to approach the septum from both sides, from the transaortic and the transapical approach. Because the transaortic will not allow you to go deep enough into the ventricle to really thin it out. You need to go from the apex and do more of that digging of the muscle now. I don't think in this case you will need to do so from this one image that we have. It's very instructive and telling us that you actually need to.
You have some alcohol ablation before that? So you think somebody with alcohol ablation?
I think that alcohol ablation was, I did some research on it, when I was a fellow. I think that was a lot of excitement and a percutaneous technique. But I think that, as the dose has settled, right now we know that this is not the ideal way, that you will end up, with a scar. You can end up having many mechanisms of reentry that will favor arrhythmias. And I think that right now, most of the centers will favor a myectomy. Now, what we have encountered sometimes is two pathologies for the price of one. Takes us hard where you have a combination of open and severe AS in a patient that is prohibited surgical risk. Then, yes, in this type of situation, you will end up doing no favor to the patient if you want to address the AS without addressing the whole, and we have done alcohol ablation. But I think that you gotta be experienced. The only operator that we have in our center that had experience on it, unfortunately, passed Dr. Angulini. So I don't think that I would feel comfortable, having people that are inexperienced doing these kind of things. Now, coming back to this case, as Mark mentioned, this is a case where you've gotta have good integration between your imager and the surgeon. When I was there working at the clinic with Mark and with Nikos Metira, we would go and we would take a look at the MRI together, and we would then go to the OR together and do the measurements, because they are approaching the ventricle from the aortic valve. And there is a little bit of that feeling that you gotta present to them as to how, when the bulk starts, then how much we're gonna shave, and then how far you're gonna go into the ventricle. Now, we had a situation in our center where the operator felt that, really no interaction needed to happen, with the imager, that he had seen a lot of MRIs, and the ventricle end, the patient ended up with a ventricular septal defect, because you can't be in a situation where you can do too much, So I think that in this moment, and hopefully this is one of the messages that you can, come out after this meeting, in the hard team approach and talking to the imagers and getting as much work done together and interacting changes everything, especially in the surgery, in the whole surgery. Do you think that you can do it without the help of the imager? You are going to get it wrong, and the patient is going to suffer.
And we did a handful of cases here for redo myectomy where they did not take the measurement how deep.
That's correct.
And so you look at half of that bulge that's gone. And another observation, we had a decline when metacaptan came out.
Yes.
We had a decline in hysterectomies, but now they're coming back. We see an increase again.
Yes.
It's expensive, the metacaptan, and I think some people are saying, but I just think it's taking care of once and for all with a very sick operation. Have you seen something like that?
Yeah. Initially there was this excitement, and then I feel like it's a lot of maybe that. First of all, I think the inclusion criteria are quite restrictive, and secondly, and so not all patients qualify.
I think that if you on practical grounds, if you have a setting like this one,
Yeah, this is
37 millimeters, I mean, you can, spill, holy water on top of the patient, nothing is gonna work. It's a mechanical obstruction that you gotta address with a knife.
For this one, I think it's going to be very hard getting from the aorta, just kind of keep it. Any other approach like going to the left atrium and take down until we could mindful and just put on a theory stage or as a bailout solution is something.
No, I think going to transaortic, all the magnitude I haven't gone through the mitral unless there is mitral regurgitation that is not explained by systolic anterior motion. So not the typical check. But otherwise it's really, it's LVOT and something. Also, we have to mobilize the fibrosis from the aortic side. We have to cut all the secondary cords. You have to cut anything that ties the capillary muscles to the section. And you have to shape the muscle based on image guided approach.
What about the minimal invasive approach in this case?
Minimally invasive?
Yeah.
It's described, people do it. I think the problem is I don't think you get the same exposure. So you end up being a little more shy with how much muscle you're removing. And you might not get the full extent of the benefit that you're trying to get when you do an operation like this. I don't do it. I'm not a big proponent of it. Maybe Mark as a kid,
Not for,
everybody does it.
not for this in particular. We've had just 2 cases with degenerative mitral valve disease and HOCM. And the HOCM was not that bad. It wasn't a 30 millimeters septum where we went in with the robot, detached the anterior leaflet and did myectomy, but it was unsatisfactory. We didn't, there are people who describe doing this all the time, but we didn't see as well as we thought we should. I don't think we did as good a job, and we don't do that anymore.
Yeah, I had a colleague in Montreal who did them through right anterior thoracotomy. And he, I would say the results were not quite,
Good.
a bit more residual obstruction, a bit more pacemakers than it should be, just not what you, couple of aortic valve injuries, just all of it.
You don't have the right instruments.
Yeah.
So you're trying to do an operation that can be done perfectly by an expert like you, and you're saying I'm going to sacrifice perfection and use instruments not made for this. You don't have the knives with the funny shapes, and you're going to use scissors. And it was, we decided just not to do that. It wasn't as good.
Mark, when we were in Bogota, actually, you were not there, but I was writing as to how pleasant it was working with you when we were together at the clinic, and specifically, I was making the point that, you are one of the few robotic surgeons I know that will actually listen to the cardiologist and to the images. And I remember you would send me cases so that I could work them out. I will call you and I will say, Mark, I don't think that this is a good idea to use the road. And you will not use it. And you will just follow the advice. And I think that that's one of the reasons why your outcomes are so good, because I think that one of the things that is important for people to realize is that if you are a robotic surgeon, not every case will be done with the robot. And I think that this is one of the mistakes that I have seen. People just say, oh no, I'm the robotic surgeon and then I have a hammer and I need to use the hammer for every case. It doesn't work like that. I think that there are instances where the robot functions beautifully. And if you are dealing, with a very complex, pathology, or if you're going to do a procedure where you know that potentially you will sacrifice the outcome, do what Mark does. Just say, no, I'm not going to go in that direction, despite the fact that I use the road. Let's use it in a diligent way for the correct.
It's just another tool.
Correct.
Second, choose the right tool in your hands. That's for you. Because it's not about your experience. It's about the patient.
In the cases that you need the upfront approach, how do you perform that? What is the point?
There's thinning of the apex in these cases. The apex should be very thin now, so you can see it in the OR. You can palpate that. You just put a couple of sutures on either side to pull it up, and the heart is literally looking up at you, the apex. And then you just do a longitudinal cut parallel to the axis of the LAD into the apex, into that thinning. And then you just see the septum is there, you see the papillary muscles that are in between them, and you just shave up to it. So you start transaortic, you do the regular stuff from the top, and then you come from the bottom and you continue, and then you try to make both ends. You see what I mean?
Yes.
You wanna move this case today, or
Huh?
you wanna move this case for today and maybe over tomorrow, or?
We can do that. Is that admitted or is that wrong?
No ha salido, todavía no.
It's not ready
No,
for-
not ready, not ready.
Yeah, I echo images.
Yes, yes. Passing to the transthoracic echo. Normal biventricular systolic function with alterations in mobility and moderate dilation of the left atrium.
You can see that lesion on the septum there, that
Yes.
that hyperechogenic correct white on the septum, that's.
And the coronary angiography, there's no significant coronary artery lesions.
And it's important to do it after these patients, but it's not so much for coronary disease, but
For
for
the
coronary
coronary.
infections. That you can have, that you then want to
Mhm.
unmove it.
Yes, sir.
There, which contribute to the pathology of the
pharmacy.
symptoms as well.
Thing.
For our part, curiosity, what were the gradings that you guys were getting on Coursera?
The,
I don't know.
the grading, no, there's no color. No color. There's no color.
Sí pasaron el catéter, ¿no?
Sí,
Puedo check.
exacto. Ok. Ujú.
Which are the anatomical references that you use to perform the neotomy, not the length, but the wide or?
What parameter do we use? Yes, oh. Sorry, say it again.
The anatomical references of
Yeah,
your limit.
It's like Juan Carlos was saying, on the long axis of the actin, what we'll like to measure in the ORT is the distance from the plane of the annulus. In this case, because the bulge starts right away, sometimes you have a bit of a gap between that and the beginning of the hypertrophy. So where the hypertrophy starts, you start to measure along the axis of along the long axis, all the way down to where the hypertrophy starts to get, smaller again. So this will give you the depth of how far you need to go with your incision. And then you will look at the thickness of the septum itself. Let's say the septum is 2.1 centimeters. So then you know you want to remove maybe 1.4, 1.5 millimeters at the most. You don't want to remove too much because you don't want to risk ending up with a VSD. And so when you do your incision, we'll start with that longitudinal incision, and then we'll cut the depth, and we try to keep maintaining that as Your first cut is really the most important. The first block of muscle.
Is there any sort
So it's
of?
three measurements. So if you allow me to use an analogy, if these were the bulge, then what we will do is we will give them from the aortic annulus, what is the distance to the beginning of the bulge? So this is when it needs to start shaving. Then we will tell them the dimension of the bulge, and then we will tell them, what is the thickness of the bulge. Now, I think that this example is right because when we calculate the thickness of the bulge, you gotta exclude the thickness of the right ventricle. Okay.
I think the gradient is 12 millimeters.
Well,
Just
that sounds right.
It's 95.
95. It's 95. Thank you.
There are two gradients that, or three gradients that we take into consideration when we are evaluating these patients: the gradient at rest, the gradient after the location, and there are two provoke. One we favor using or two or three ways of provoking, two that we use right now, and one that we do not find use. In the rural days, and actually I did research on it, we used to have provocation with the and we are shying away from doing it like that because it's just not physiological, right? But there are two things that we want to use. The best way is to provoke with exercise and to really figure out what range you're getting when the patient is put, in the treadmill. And then there are two other maneuvers that we want to use, and we're completely very light the provocation with ammonium nitrate. We don't have in Houston, and then also the provocation with the Valsalva maneuver. Then the cutoffs that we use is in a baseline, we have a gradient more than 30, then that would be significant, or more than 60 millimeters of mercury with provocation.
And that's why it's so important to provoke the patient, because outcome is a disease of obstruction. It means that even if you have an okay resting gradient, but then when you provoke, the gradient goes up, their risk is just as bad as those who have a resting gradient over 30. And they have an indication for intervention. So it's almost a third of the patients that will have a resting gradient that is okay, but when you provoke, you elicit that high gradient. And these patients have the same prognosis as those that have a high resting gradient. So just a normal gradient on the resting echo is not enough in a complication. You really need to provoke the one way or another.
And then the other point, is the risk of sudden death, that you can assess by the thickness, of the bulge, but also by the amount of delayed hyperenhancement that you have, the amount of fibrosis that you have. The MRI guides will help you, in addition to the mechanical decompression of the ventricle after you do the myectomy, to select whether the patient is sanitizing you or not.
You have the AHA app now that really helps you.
Let me introduce you. Dr. Rios is the chief of the consultant in the institute.
What do you think about the valves? There are some locations. Could you put the echo? We have some problems with myectomy previously when it has some elongation of mitral valves.
Yeah, we were just talking about that a minute ago.
Looks something like that.
You want to comment on this, Michael?
So again, I think, as I mentioned, with the initial case, this is a case where you want to take a very nice look. I don't know if we have a nice key. I mean, over here from the images that you have some thickening and calcification of the anterior and the posterior leaflet. But I think the point that we were making with Dr. Gilliano is, and I think that this is what you're referring to, is if in addition to the hypertrophic cardiomyopathy, you have some primary structural pathology in terms of the positioning of the papillary muscles. And as I was discussing, what happens is that if you have, I think that Nicholas the bigger calls it the papillary muscles, where it comes like this. What you need to decide is whether you need to bring them together so that you will prevent the anterior migration of the papillary muscle. It's not anterior leaflet, and it is not intercepting even after the myectomy has been performed.
And that anterior leaflet was a little long,
Yes,
so you might want to consider moving those papillary muscles pulling away from the
that's
outlet.
correct. Because the point that I was making is, if you have two pathologies for the price of one, you can go and be very successful in terms of doing your myectomy. But as Dr. Kirillov mentioned, the anterior leaflet is elongated because of the positioning of the papillary muscles. It's going to continue in the septum, and the patients will remain with LVOT. And this has been served, especially if you're going to be there in the chest. But the same concept applies for the very few instances where alcohol ablation is done. If you don't recognize that, then the patients will come to you with continued symptoms. So I think that one of the messages that you need to remember is in the same of hypertrophic cardiomyopathy, just like you're asking, sir, take a look at the anterior leaflet, take a look at the papillary muscles, and decide whether there's something else that needs to be done. Another important thing that we have not taken a look at the course is the direction of your jets. You know, there are jets that are normal and expected in the setting of systolic anterior motion. But if you have jets that differ from the direction, then you gotta say, you know, something else is going on, you know, with this microbiome, and I need to tackle that, you know, as I approach this patient.
¿Alguna otra pregunta?
And we propose the next plan is a Morrow myectomy.
We don't call it Morrow.
It's
just like cut the muscle, whereas this is an extended supplement. We really want to address not just the muscle, but as we were all mentioning, all the elements that contribute to the function and the structure of the LVOT, which is the muscle is the most prominent portion, but often enough the trigeminal will be also fibrosed. You need to release that to allow that hinge mechanism between the aortic and mitral. You want to release all the secondary force from the leaflet of the anterior leaflet of the mitral. You want to either relocate the papillary muscles, but it's also important to cut any cords that tie the papillary muscle to the septum. So all of these things will be the so-called extended myectomy.
Okay, thank you.
And again, the bridges are important to keep in mind, myocardial bridges. If they're present, you have to undo those arteries.
That's exactly. Okay.
It's the same with the cannulation is the same.
Yeah. Again, I think I cannulate everything in the arch, just because everything I do goes through the aorta. It gives this way, it gives you the whole aorta, whether it's long or short or C-shaped, or you never have it slanted in the way and you're fighting with it. You put the clamp way up toward the abdomen, and then it just gives you ample access to whatever you want to do. So I always undo the pericardial reflection of the distal aorta, release that, and then you see the anomaly from the left carotid. You cannulate just at the base of the left carotid. And I do it over a wire, and just put a needle, a wire, and then the aorta cannula over that.
In the lower part of the arch.
Yeah, in the upper part of the arch. Only the small part, which is
In the upper
part. Yeah.
Okay.
Any tips on how you'd like to make your aortotomy to get the best exposure?
Yeah, for the myectomies, it's we'll start a little above the sanguinary junction, and then I'll extend it into the non-coronary. And then I'll take the non-coronary cusp with a little 6-0 and back it from outside of the aortic closure. We've dealt with one of the 3 lesions and then the 2 others. Correct.
I think the operating room is
From me.
start.
Sergio.
Okay. Of course, if you like slightly,
Because they are.
So which room is this? This is the aortic room or the
No,
mitral room?
the mitral.
And they're regulated? I still don't know, sir.
Aquí está esto, como para que se vea en grande. ¿Cómo se hace para que se ponga en grande? Ahí va. Ya le di doble clic, le di derecha.
Pues una blanca. Sube el nivel. Un poco más. Ok, listo.
Yo también no le he nada ahorita.
Esto es una seda. ¿Puedes checar tu gradiente, por favor? Oh, ok.
It pops up. It pops up. It pops up.
No, don't worry. We use for another thing.
I'm not worried.
Cuidado, una aguja. Pickups and knife.
Es una pizza. Cinco.
Knife.
Lo único que tienen recta para la superior.
Mommy. He's tiny, so he's on No.
We use Pacifico for this one.
Little metal tip. I like it better. I don't like it.
This weekend, this for now.
Voy a necesitar I mean, the.
Yeah, I have the one. I have the one. Just leave it. We just connect this for now and then we connect it at the bottom.
You're gonna use the what? I'll show you. But I mean, I want everything this way, back behind. Okay. I won't ever flip it again. And I will have this, put the white here, and it goes straight underneath the retractor, that way you never see it again. Entonces, ¿cómo te mostró?
You have the. Patient has CFO, right?
Yeah, this is.
Está bueno. Tiene como un doblez.
Sí, se le hizo ahí ahorita venía.
Put it underneath. Here, aquí.
Kelly? If you want, we can change it. Over there.
Underneath your side, I think.
Okay.
Yeah, either. That's perfect. Okay, great. Okay, that looks good.
You want so?
Are they ready?
Yeah,
We can
ya
do
está,
this.
estamos listos.
Hold on one second. Let me have a curious.
Aguanta tantito todavía, ¿no?
It's like real quick. See now, just before we start, we can look up here and see what.
So,
Thank you. No, this is. It's the biggest for which the picture is just for a person who was published like this one second. We could start in place for that space. Because this is correct thing. If you'll just hold that like that, can I get this to you?
yes,
Or you'll think it? Thank you.
vamos a empezar, por favor. Do you like it? 32,
Whatever you want.
32 grados.
Whatever you want, we can just put that and we'll get the plant and we'll get the integrate. ¿Tienen un control?
Do you have the camera?
Here's where we'll stay on. Usually on the mask is better. Usually up here is better on the mask. On here, here, this side. Yeah. One in the place, you want to put it. Okay. In the here? On the mask. Okay, in the mask. And aquí en la. Aquí es la works better there. Yeah, good. You're comfortable in this place? Thank you. Okay. Yeah. I'm just gonna have you to put the headlight. Yeah. Hold on one second. Okay.
Okay, you can put it on my head. Needs to be bigger. No, no, bigger, not smaller.
Okay.
I never wear a headlight.
That's the
Okay,
biggest, but I can.
okay, now tighten it up a little bit. Okay, that's good.
Okay.
Now you have to clip it in the back somewhere. Hmm.
You want me to adjust the?
Yeah, it has to go here.
If you want. For the hand or?
Yeah, well, I'll use that in a second, yeah.
Better?
That's okay, I think.
Or do you want me to put it up?
No, it's okay.
Oh.
Thank you. You guys just tape that to my back, just tape it now. Tape this with a piece of tape.
Yeah.
Yeah.
It's okay.
Thank you. Oh, this is the first time I've got a case with a headlight in like 10 years or 15. You know, I wouldn't agree to it otherwise. Right, now we have to do this again. See, it has to be centered. Good. Okay, here we go. I'm gonna stay where you are.
Okay.
Yeah. You and I will do it together. What do you think? Great.
Perfect.
Thanks, man.
We already put the patch.
That's great. Yeah, that helps the right ventricles. Okay, so now we'll take this little retractor blade.
Okay.
Yeah, you can see how we can do it right down this
Okay.
tunnel. I love this
So
because this retractor
you only
really
need this.
exactly,
Okay.
especially someone this small. This retractor really helps us because MJ, can you help me with this thing? What you can see is the beauty of this retractor is, and I'll show it to you. Because I can set it up. Okay, I'll just take that sucker a second. The suckers.
Ponle tu soca, ¿eh?
And then I'll just take those scissors again for a second. And scissors a second. This is fun because we saw on the echo the atria was really big.
You use a normal auriculotomy.
A what now?
A normal auriculotomy. O sea, you don't use a small incision in the auricular.
Everybody.
Okay.
We do a small incision in everyone like this. We can do triple valve surgery without a incision.
Okay.
Now watch that. Here's the key. Now hold this, please.
Hold it.
No, this way. Yeah, just to the heart to relax for a second. And so what happens is that you see that in this, you can see how small the atria is here.
Yeah.
But this retractor is extremely, you see I can set my blade depth.
Donde
anywhere.
quiera. Okay.
And then what I can do
Perfect.
is go like this.
Oh. Perfect disposition.
Yeah. And now what they can do is raise the table a little bit.
What do you need?
Raise the table.
¿Pueden subir tantito la mesa? ¿Podrían subir tantito la mesa? Anestesia. You say us.
Where's the other? There it is. Thank you.
Is that all right? Or do you want?
Yeah, that's perfect.
Okay.
Okay. And then this is the other really cool part of this retractor is you can see now I'm still in a very small port.
Yeah.
But this was the cool part was that, see, now I can do this.
Ah,
I can create a working space without external separation.
perfect.
This is the key part of this retractor, is by doing this, I can double the size we work through without spreading the bone.
Perfect.
And that lets us really have almost no pain
And
afterwards.
what is the name of this retractor? Okay. Okay.
It's a Delacroix. If you invite me, if you and I work together, if you and I work together twice,
Uh-huh.
then I bring one and leave it for you.
Okay.
And it can be your retractor.
It's
And it's amazing.
Yeah.
These blades, this piece
Uh-huh.
can be deeper and wider. So it's
Wow.
perfect for any size patient.
Wow.
So you can use that for anything. Let me see you tie a knot. Let me
Sí
see
le
you
puedes,
tie a knot.
o sea, quiere ver cómo haces tus moves.
Oh boy. Okay. You and I have some work to do later about your knot tying.
Te va a poner a hacer nudos.
You and I will have a discussion while he's doing other things. Okay, Sky, just before we start, we promised we would close the attendance because she has a history of paroxysmal mitral fib, right?
Yeah.
Yeah. So, and then you can see this retractor helps me so much because see, I can bend everything out of my way now. I have no tension here.
Okay.
And now we just close this first. Fix this side. Okay, Mary Jo, you have the four following. Okay, so we have to hold this in one hand, hold this in this hand, and hold this one tight. Yeah, good. You put all these clips on now, so if it's one snap.
Yeah.
But these, so it's still fine to do it the old-fashioned way. It still works.
I prefer it too.
Yeah. The key is just taking your time. All these guys that have leaks, they don't take their time.
Let me see one.
Yeah.
You close this like an aortotomy, it doesn't open up,
Yes.
right?
Yes.
The problem I see is some surgeons are in such a hurry, they forget to be precise. Like you're precise on an aortotomy,
The
but
best
they're not
surgery
precise here.
is the only one.
One time,
Yeah.
exactly. I can't stand people that do things close.
I agree with you.
I once in my OR, I had this young guy, he was study, was really hot stuff, and he was doing a, I'm in the room doing the mitral, and he's next door doing the Ventolin. He pops in my room at like 9:45. Hey, what are you doing? I'm like startled, and he goes, I've already finished my Ventol. I'm like, oh wow. They said, yeah, only 45 minutes. I'm like, oh, okay. So then I went to my next room, and I did my second mitral valve. So now I've done two mitral valve repairs, start to finish.
Uh-huh.
And then I look in the room and I see that the drapes are on and the whatever in this other room. And I'm like, wow, are they already finished with their second case?
No, it's the first.
It's still the first case.
Yeah.
They're still trying to stop all the bleeding.
Of course.
But the clamp was only 40 minutes. Okay. You know,
Yes.
I told you, I've already watched enough for you to know you and I have the same surgery idea, same idea about surgery. Also, I mean, I don't like BS. I don't want to BS, but I also just want to be careful.
Of course.
Let's see. Let's turn the vacuum up. So we don't want this here because that's
Pueden
bad for
subir
the
un
right.
poquito la presión negativa, por
That's
favor.
bad for the right ventricle. They should be able to decompress this. If not, I'll open it and help them.
Él quiere que el corazón esté totalmente vacío.
It's not good for the right ventricle. It takes as long to do this as put the ring sutures in mutually.
Uh-huh.
what do we have to be careful about when doing this? What do you think? Can you ask him that in Spanish?
Te está preguntando qué piensas que debes tener cuidado cuando estás haciendo eso.
Like, why am I taking so much time? No, but what am I worried about?
¿De qué se preocupa? ¿Te preocupas? Anatómicamente, ¿qué hay ahí?
Yeah,
¿Por qué lo hace despacio?
the, the circumflex artery is right here, right? So we have to be careful. That's why it takes a little extra time because you have to be flatter on one side than the other. Worth it since you have this history with it.
Yes, of course.
If you did, it'll be worth it to the patient for us to take the extra 5 minutes and do it. Thank you.
Okay. Perfect.
Okay, can they see or hear anything? It doesn't really matter to me, but
I can see.
no, I mean, I don't know if these guys watching can see anything.
¿Están viendo bien la filmación? ¿Se ve? No tenemos aquí un monitor para... ¿Sí se ve?
Great.
Se vio perfecto.
Ah, thanks, Mark. How you doing? We have a good view of everything.
Yes.
What's your last name, Roberto?
Martínez.
Martino. It's nice to be able to remember both sides' names. All right, so let's have our valve analysis real quick. So we're just doing a quick valve analysis just at the first step. You've got a shelf here that's not completely normal, which really fits the anatomy we saw in the echo. You've obviously got a type 1, but you can see it's not a very normal posterior leaflet here.
Yes.
This area is actually not very symmetric. Very tiny valve. Very small valve.
Did you see some retraction, David, there?
The posterior leaflet for sure.
Yeah.
We're just looking at the anterior leaflet to see what we've got here. It's out of
To be
curiosity.
honest with you, I just took a look at the images in the T, and I didn't learn anything different from what we discussed downstairs.
No,
And I think that I see some, maybe a little bit of restriction, but I do not see anything wrong.
Okay.
so at any rate, I did that for the audience. The first step's always to put the ring sutures in. Again, it's so small, we just have to be thoughtful. Okay, so you're just going to put a snap on each one of these.
Empiece ya. ¿Todo por abajo?
We video flex ring, so we only need this many sutures, but we'll put the rest of them
Okay.
later for whatever kind
Va
of
para allá.
ring or candy.
Sigue acá. Ah, no, va por ahí.
Here, that, and here. That.
¿De este lado? ¿Alcanzas o si no lo va aquí?
Thank you. We're being afraid to cross things to get good bites.
Okay.
Because we can always respect that on the ring. So that will get us started. And then what you can do on your side and what I'm doing is just snap these to the drape now. Because what they'll do is you can just snap it out. Now all it does is give us a little bit of an annuloplasty effect.
Que lo agarres con
So
los campos.
So what we'll do now is we'll get you to pull these up just like I'm doing.
Okay.
What we're doing is creating an annuloplasty. See how we're creating, look, watch, see how we create an annuloplasty effect? So each time we do that, we create a little bit of an annuloplasty effect.
Okay.
So now we have that. Then a towel goes in front. So now we don't have any distractions to do proper analysis. I like everything organized, so we don't have to. Okay, so now we can look again.
The second look.
And now we can have a real one. So let's just see if we can figure out why this thing wants to leave. So we don't want to be there. Hold this, please. Hold this now. I'll hand you that hook each time.
Okay.
Yeah, I'm gonna keep it for each time.
Anterior.
Anterior.
Just because it's in our face and we can see them easily. Now the posterior leaflet has this abnormal shelf here.
Okay.
And this is not. Here, it's always easy when it's clear cut.
Mhm.
It's less so, but I think you want to be more thoughtful. Okay, so
There's some traction over there.
there is traction.
Yeah. Okay.
Okay, so now make the next decision. The sailing test will be, this is really useful when you've got leaflet work to do, but here you're really thinking more about subavar apparatus. I like to relax these a little bit.
Okay.
And what that does is let the valve drop back down just enough so that now we can interpret our sailing test a little bit better.
Okay.
But you can leave this sucker right here for a minute. The marking pen a second. Most of the restrictions here.
Yes.
Hola, ¿qué tal? Nicely.
¿Nos escuchan?
Thank you.
Hola, ¿nos escucha?
No, es
So that's good. Now, you can see how the ink is
You wanna
right
talk?
in the line. You see that?
Ajá.
So anytime we have ink that's in a closure line, we're gonna remodel that a little bit. I'll show you what I mean by that.
Okay.
Okay, so hold this, please. You see that's a marginal chord.
Ajá.
We're gonna cut the marginal chord like so. Because we can't, if we close it with that in there, it won't work. And actually, that was very thick. You see how abnormal that chord was. So I think we're happy that we got rid of that.
Okay.
See, this isn't normal.
Just read what he's saying.
Uh-huh.
A little closer up there.
Okay, knife a second. Then the 5/0 flowing. I mean, this is one of these areas that will leak. So you always want to try and what we call free edge remodeling. So we cut a thick marginal chord there, and then we'll take a very small, almost magnification right at that free margin, trying to close this area together. Right where we cut it. Um,
David, it's Mark Gillinoff. You're just evening up the free margin.
So when you tie knots, you put two different fingers down and have two different maneuvers. And at year 3, you really want to learn one thing over and over till you've done it 20,000 times. See, I'm only putting one finger down and only doing one motion. I'm not locking anything. You'll find you'll get much more accurate if you do it like that. The other thing you can see now is this purple line is there's leaflet closed above the purple line, which is really what we want.
Mhm.
Such a small valve. Normally we would only you could do it. You see how that line that up better? See, now those purple lines are more symmetrical.
Yes.
That's what we need. Because again, we don't have an angioplasty yet, but you see how now it's a symmetric smile.
Yes.
So the valve is tiny, minuscule, such a small valve. What kind of rings do you guys use here? Is it a classic or
It's a classic.
Physio or
No, it's a classic.
a classic?
Yeah.
Good for you.
I don't know if you bring another one, but.
No,
Pero,
I
¿qué
don't
clase de anillo
care. I just
tenemos?
want to know what that
Es de
box
clase.
says.
Fisio 2? Fisio 2.
That's what I'm afraid of. That's the one I don't like.
Yeah.
I invented it and I don't like it.
Mhm.
Not for this size valve. Because it's a physio too, we have to be a little bit careful because it's a very hooked valve. Now, way to see the long axis again.
Podemos ver
Always
¿nos
look at
pueden
the,
enseñar el eje largo? Por favor.
you should always look at the long axis. And you guys don't have any bands, like any kind of band for a valve.
No. ¿Tenemos algún tipo de banda para las válvulas? No.
Any bands? Or band by anybody?
No.
No. Okay.
If you want, we can make one.
Oh, I know. We can make it out of paracardium if we
Yeah.
wanted to, but. Yeah, the long axis, that's the 4-chamber.
No, necesita un eje largo. No está por aquí. ¿Solo tenemos los fisio? No tenemos ningún otro. No.
That's okay. Make it work. Okay, so then we have to, just because it's so saddled, because the reason we invented the next one is because that Physio 2 has got a big saddle for small valves. It's not ideal. Large valves, beautiful. But if I'm between sizes, this type one, we like to downsize one size. Then what we'll
Yes.
do is we'll drop it. So we can look one last time on it. You have that test string, because normally I'd use a Physio 2 and use 20. I mean, a Physio and use 28, Physio Flex, but it's gonna be super fluid. So see what's happening without the wheelplasty effect. Now you've dropped it and we ignore it. See that? Let me see the 26 and 28 size again. That's why it's important to know there was no regurgitation for athlete, because so you really do need the wheelplasty effect because of the traction on the leaflets.
Yes.
Okay, you will not have a great. Let me see the 28 real quick.
A ver, perdón. In the room, want to do a question.
Yeah,
A ver.
you can ask and answer because you know it all.
¿Cuál es la pregunta?
Yeah, can you just put that back on the long axis, not the 3D?
Quiere el eje largo, no el 3D.
We could just. Here, can you guys hear us in there?
Yes. Yes.
Wonderful.
It sounds like you might have preferred a band to a complete ring.
Yeah, in this case, because it's a small valve and the Physio 2 has a large saddle. So that's not a good combo because we really have, and we like to downsize these sort of type 1 with restriction anyway, especially in someone that didn't have a gradient. That's why I'm asking to look at the long axis to make sure we have room for it, which I think we do, but that's what we would always put in a band. For this particular situation, we would use a PhysioFlex these days, but an open prosthesis of some kind because of the size of the valve. But you see, you've got this little bit of inflammation at the tips. You do have to be thoughtful here. You don't have a normal coaptation zone. So that's why I asked for the long axis, trying to make sure we don't get systolic motion, which you can get in any size. But I think this is the safer one for that particular anomaly that we're looking at here. I think you really do have to put it, especially with the saddles of the 20 or the Physio Flex, you've got or Physio 2, you really need to have that extra thing. You see, as I've dropped the valve down now into its normal position again by relaxing the strings, you can see it wanting to leak. So it's really important to make sure you have enough
room.
Dave,
yeah,
no,
you can see how we're more, you see this one too. I'll just show you, pick up some second. You see how this line goes through the free edge here, which is what I thought looking at the echo. So I'm holding my forceps here and I'll take a 5/0. When I pull this down, you can see I can create this little thing and I can see the purple line. And this allows me to remodel that again. Just this much.
You're going to align.
Yeah, just so I don't have to worry about it leaking through the closure line.
Okay.
And so this little itch here.
This is Abe again. I have a question. Since
This
you're
also helps us pull the leaflet down. Yeah.
I have a question. You're having to modify things on the fly. Would you be adverse to cutting a ring, just modifying a ring and creating your own band out of heavy enough scissors? I guess you could do it.
You can't really cut the Physio 2 or you're gonna, the steel, it's a steel band and I think it's probably, I've cut a lot of different flexible bands over the years, but I haven't cut a lot of steel steel bands. I mean, I guess you could try anything. I think we were better off just, just to show you guys.
Surgeons
where I
probably
put the
have the
sutures
weapons
is
you
where
could
we
use.
Normally use every suture. Now, we never have to put any more sutures in. We're at the base of the anterior commissure. We're not cross. The trigon is here.
Mhm.
And hook a second, and we're just at the trigon posteriorly on this side here.
Mhm.
So normally that's our construct. We like to stop below the commissure here and go one bite past it on this side.
Okay.
Sorry. So, and I'll just take a couple of more sutures and we should be ready to go. Wait here. Yeah, that's the one thing I don't.
So you like to put the anteriors on?
I usually don't ever put
Stitch.
these, no, we never use this rings and we
Okay.
never use complete rings. So
Okay.
we don't use these
Okay.
sutures anymore. It's not a big deal. It's just that's how we would normally use a physioplex,
Okay.
doesn't make any difference, or a stimuloplex. Okay, so one last look at this thing. Be sure I'm happy. And you have that 26 sides ring.
You're going to downsize.
And when I'm between sizes, I want it with a physio too. I want to go down.
Okay.
The saddle's prominent and that's why I asked to look at this. The angle's open and you've got a type 1 dysfunction. So I think all those things tell you that if you're between sizes that you're better off with a slightly smaller ring. The other thing is if you just mark into one last time. Because see, now we've got these two sutures and we've hopefully created a little less motion posteriorly, which should give us a better coaptation bar for the long haul.
So,
Look a second. You can see how little this coapting. See,
yeah.
if you get greedy here, and look how rough this is. See, it's
Yes.
not normal, is it? See what I mean?
Mhm.
That's why you really want to make sure you have enough of a closure here not to leave her with or recurrent MR. Okay, we'll take the 26 physio too.
Va a ser 26. 26.
And then you see this little tear here.
Mhm.
So whenever you see that scissor a second, you shouldn't leave that. You should just replace that. What's happening is this retractor, even in this, with this little small retractor, because the atrium is small, it creates tension. So normally you want to let this down a little bit so that you don't have any tension when you
Okay.
put that suture. And then you need a hook a second. If you have trouble seeing that, then if you get your hook
Okay.
like so, then I can really take a real purchase of this and then pull it all down. See, I don't want to have this tearing.
Yes.
That's where you get the distances of the ring. Just put this last little guy in this. Follow it that way. Okay, that goes up there. That. And now we're just going to go across the top first. Let's see what we have. Physio 2, 1, 2, 3, 4. It's like a very small valve.
Yeah.
As you can see, 2, 3.
What's that?
So you'll hold it here for a complete ring. You'll load this forehand for me.
Lo pones en derecho.
You'll load it forehand.
Forehand.
Okay, so let me just teach you again. Whenever you're loading a needle for anything in the mitral world, it's going to be that. It's going to be your default. Okay. Yes. So then we're gonna take the white one. And I'm gonna give you another chance.
Vamos a tener que hacer 500 veces eso.
Voila, see? Trainable, huh?
Yes,
What do you
yes,
think?
indeed.
You can see how small this valve is. I can't even four sutures doesn't get me across the top. Or barely. Okay. Hold on a second, give me that. Okay, so now those will all come in the front. Great. Tiny valve. Okay, so these go this way now. Now you're gonna hold for us. 1, 2, 3, 4. You should have 3 on your side, which you do. It should be close to the middle, which it is. Okay, remember that, so we'll just put this one on either side of the green one each, and then we'll do 3 on each side. Yeah, you go ahead now. No, it's your back now. Here? Yeah, anywhere, that's fine. Good. Okay, so we're gonna go this way first. We have to go both sides. So you're gonna hold, yeah, you should be able to hold and pull at the same time. Put those in your finger right here. Yeah. Okay, now you go right beside the green one, or just a little bit over. Good.
Vamos a cambiar de lado.
All right, so you have 3 to go to the other side.
It's okay.
Treble, just a little more treble, just a little more on the bottom one because it's stronger.
Over there?
Yeah, just like that's perfect. Good. 3 to go. Okay. Let's see. Go in there a little bit. Okay. We should have 1 point. See if I've done my best here. Probably do that better. Can you scissor a second? Ready? Have better exposure of everything. It's just the first feature. When it's the last one, you can really get a perfect bite. Okay, this side is for you. She's going to hand that to you. Great. Thanks for enjoying. What's your name?
Tadeo.
What is it?
Angelica.
Angelica.
Mhm.
Oh, like an angel.
Ujú.
If I come back, Angelica, you're gonna have to work with me again.
Que cuando regrese aquí, que si vas a trabajar con él. Ujú.
Okay, I think that's a good start. Let's just make sure we're on the same ball field. Very saddles are very hard to incorporate. You got it. Come off with the physio too. This is one thing that Rapunzel I couldn't agree on when we designed the string together. He wanted the saddle to be fixed and I wanted it to be
Mhm.
flatter and small sizes. It's like, I think the saddle is too big a hump when it's this small.
Okay.
We'll see. We follow all the principles, it usually works. It's a bit saddled for a restricted leaflet, isn't it? I think with the restricted leaf, you really want a flatter profile, ideally. This deserves the physio flex.
Sorry for that.
Not your fault. It's all the government stuff.
Yeah. That's our problem.
But you guys. Today, I'll get you to tie these in nice and tight, huh?
Yes.
Tie these up nice and tight. Angelica, like an angel, right? What do your friends call you? They'll call you Angelica? Or they changed the name? Angie, Angelica,
Angie.
Angie. Yes. Yeah, let's keep going. We got the right size in there. So let me just relax this just a little bit. Again, one of the keys to get these things is trying to relax it just enough so that you don't feel the atrium will come to the ring. Okay.
Thank you. Perfect.
Yeah. And that's what we want to see for a type one. If we really see where my proing is inside the pleasure wing.
Mhm.
That's what we want to see. That means everything is available for cooptation. Now we still have to mark one more time to be sure we're not having created stenosis. I'm sorry, Sam, because we can always displace this if we wanted to.
Okay.
That's good. So we've got just, our goal is always trying to get this much coaptation,
Okay.
regardless of the ring or the size. If we can get to that coaptation zone in general, we're very happy with this kind of coaptation, just like that. So I think we gauged that well. Now we just take one last look here. So we didn't close it to the tip.
Mhm.
And the sign is still very well supported. You see, we left the very tip of it open for inflow. I don't think we can do it better than that. You agree?
Agree.
Okay, the table toward us, please.
¿Puedes darnos ahí para nosotros? Bueno, para el doctor.
Okay, now we have vacuum on.
¿Tenemos la aspiración? Sí. Sí, yes.
Okay, just stay there one sec. You have to be sure we don't have to do anything here. Turn that pump sucker up a bit.
¿Puedes parar
Okay, the pickup system.
la aspiración, por favor?
And the valve tester in a second. Let's clamp that. Another forcep for a second, please.
Forcep, please.
Just to clear that for a second. Let's see this. Get the other sucker in, sucker in 6 seconds.
Pásame el otro socket.
Oh boy.
El otro aspirador.
Where are we?
No, please.
Okay, vacuum up and flow down a sec.
¿Puedes subir la aspiración y bajar el flujo, por favor?
Okay.
Ahora bájanos el flujo.
There we go. Okay, that's really work. Okay, that's all I wanted to do.
¿Listo? ¿Ya suben el flujo?
Okay. Now we'll take that suture with Ria. Really appreciate you doing this with me.
No. For us, it's
Nice.
excellent.
I know you'd rather be over there doing that aortic case, but there's some more of them. I'm
Yes.
sure you're going to get one. Before you're done.
There's only one. There's always one.
Yeah. Okay, you've got to follow with him now.
Okay.
Lego.
Tienes que seguirlas, llevarlas a su tiempo.
Yeah.
Te voy a meter un poquito el aire. Tranquilos, si tienes problemas me avisas.
You're warming up.
Empiecen a calentar, por favor.
Okay, so get your forceps in your other hand, hold just like that. There you go.
¿Tú lo llevas?
What's your name?
Tadeo,
Paleo?
Tadeo.
Paleo. It's like Paul.
No, Tadeo, with T.
Oh,
Fer, ¿le puedes avisar a los de Eco, por favor? Gracias.
feel it nice and tight. It will be here for a while.
Yeah. So, Holy time.
Yeah. You obviously have the extra surgeon.
Yep.
You can see that you've always been able to do this for a long time. You guys happy with your ICU?
Yeah.
It's always a struggle.
Yes. It's hard.
And we need to blow the balloon. Yeah.
La jeringa de 3.
Y luego tienes
¿Vas a descansar?
Yeah, I'm going anywhere. That's the line. Fine. Let's move here. So are we giving retrograde now? That's my major
¿Quieres la
question.
frecuencia para darle directa?
Is this going? Okay. Dame una fuerza. Oh, those scissors. Scissors? You wanna cut the phone? Yeah, these are good. ¿Te está dando carriplegia o no? ¿Sí está yendo? ¿Sí sale? Are we giving retrograde? No, no está dando retrograde. Tienes que abrirla. Antegrade here. This is Tienes que abrirla. These guys are giving antegrade carriplegia. Okay, stop it. Es para la carriplegia. Dame un pensamiento. Y dame las canulitas para la directa, las derecha e izquierda.
Izquierda, una de 45.
Okay. You gotta give me some direct carriplegia right now.
Left?
Connect this. Yeah, direct. So disconnect this one.
Connected, I'll get it cut up
Okay.
so they can see it.
Le vamos a dar ahorita.
Van a pasarlo.
Okay.
Estoy pasando.
Agarra una fuerza aquí.
Anterora.
Agarra una fuerza aquí. Mark, can you look at this?
Hold on.
Mira.
Okay. Put a section in here.
Okay, dale a la izquierda. Directo en la.
A la izquierda, directo.
Okay, now you're giving carriplegia.
Now you're gonna give something to the right too if you want to.
Yeah, we don't have two handles.
Yeah, you can use the other one from the
Retrograde?
¿Ya? Kelly?
Hey, Mark, this is Abe. Can you hear me?
Yeah, you got another hand?
No, just my only hand.
Ya cierra la puerta.
Cerrada.
Sí, dale, tenemos que ir a la derecha también ahorita un ratito. Las leaflets están todas destruidas. ¿Ya viste? ¿Ya tenemos arresto o todavía no? ¿Cuánto es la presión que le estás dando?
152.
¿Me prestas la derecha?
¿Y cuánto llevas? La otra probablemente a lo mejor no.
400.
Dale.
Oh, come on. What the fuck am I doing? Touch ID, I'll get her. Oh. Yo quiero hablamos con
De hecho, está abierto.
Mark. Mark, can you hear us?
Ah, no.
Let me give me a second.
Esas moscas. Me voy a echar.
¿Cuánto va? Yeah, good.
Pero los
Échale todo helado y nomás agua bendita. Nuts and bones. Nuts.
nuts and down in.
Yeah, nuts and bones. Gracias. ¿Cuánto va? Está bien, está perfecto. Está descomprimido el ventrículo, estamos a toda.
Necesita purgar el derecho, creo que tiene burbujas.
Okay, these are, all these liquids are abnormal.
Vas a cambiar la bolsa. Ah, ok.
Échale lo derecho.
¿Ya?
You're not getting there anymore.
¿Te va a purgar la
Sí.
plegia?
Nothing's coming out of the right.
No sale nada.
Púrgale.
Dale.
¿Me prestas? El territo.
¿Cuánto va?
Para la válvula.
Sí, es buena dosis. Está.
Sí. Sí, sí, sí.
Okay. Now, we're gonna question the audience, Mark. So,
Oh, yeah, okay.
okay.
I think probably one of them, two, we need one of them off. I think that's maybe your phone is actually. You guys can hear us, I presume? Maybe not?
I can hear you. Can you hear me?
Yes. Yeah, we're just starting. We gave direct antegrade into the left and the right. It took us a minute to sort of gain access to that, but the leaflets themselves, all three did not look good.
All three were
Are you using
retracted and shrunk up. So now we're gonna finish up the cardioplegia and then cut out some buttons and size this. What do we ask for size?
Ábrese ¿cómo se llaman las medidas? ¿Cómo se llaman los medidores? Okay.
Do you prefer
¿Cuánto va?
resting with integrate? Or would you ever rest with retro and then open up while you're getting?
Okay. Déjame un ratito más, okay? So carry pleach is off. Ajá. Bueno, retrógrado no sé si funciona o no, pero si no le damos otro shot de ratito, ¿no? Ahorita que lo abramos. Dame una pinza.
Get the aorta off it. Yeah. Then I need you to hold that part.
Hold on a second.
Yeah.
La tiene el otro en la mano. Here. We're here, I guess.
Yeah, work our way down to that a little better.
That's gonna be you.
You grab that?
Yeah, hold on a second. Let me. This thing is.
¿Cuál es el problema?
Problema 5-0. Ah, bueno, para. Disección vascular.
Una una piecita.
Tienes una más larga, Lili, está muy cortita. ¿Quieres una carga? ¿Quieres más larga?
That's the button, yeah.
Okay, good.
So
Let's go down the
you know,
road.
secure. Hold on.
You got it?
Let's move this one up.
Está más larga.
So this one, I don't know, is a branch.
No, I don't think
nothing.
it's anything.
I can move that thing here.
Yeah. Okay, we go here.
Ahí está.
That might be
A ver aquí con este lado.
a little bit more over there.
That's good.
A little bit.
They're right pretty high.
Yeah. Okay. That's probably good.
Eso.
Got it.
¿Tiene un problema, por favor? 4.
¿Me prestas protegida, por favor? Gracias, Lili.
Okay.
¿Corte?
Yep.
Aquí.
Good.
Deme otro por el derecho.
Let me get some quadrium on the back there to over this way. If not,
Okay,
then
hold on. Let me. This side.
onto the top so we can move it.
You're gonna be root here.
What's that?
Hold on, so you have the atrium here.
No, I know, but we don't need to get that.
No, this
Oh,
is too good for the commissure here.
let's get this, pull that your way.
I mean,
Oh, buzz here.
okay, ¿cuál es la pregunta? What is the question?
Mark, do you ever use just retrograde to arrest and then open the root?
Yeah, we had considered doing that and we're gonna try to do that, but we weren't certain our retrograde was going in efficiently, so we have the medicine bug.
We have a hole in the cannula of the retrograde, so that's why we feel safe about it.
I was trying to keep that quiet, but yeah, so we kind of slowed things down and then opened up and got direct coronary access. We're just cutting around the right button right now. It's pretty small. Very thinned up, very abnormal aorta. Okay.
You got another 4.
Yeah.
Trim it.
Let's buzz a little bit of it off or clean it up behind there a little bit.
Hold on a second. You got this one here?
Yeah, right. Yeah, that one. Maybe a little. That's enough there.
Yeah.
Oh, right here.
You got a little branch
that
there.
way. I'm gonna get this part off. This is nothing here. That's good enough.
Or so you care about it, or just to keep it for now?
Yeah, sure. Yeah, yeah. Medicine bomb? There it is. There. Here you're gonna-
Luego tiene los puntos ya, los de los dos O.
We'll trim it up a little more.
Yeah.
Préstame el 4 ceros. Let me,
4-0.
You got it?
Yeah, I got it. You just
Mark
put
the
it.
top.
I'm just gonna put my top.
Yeah.
Four.
It's right there.
So we put the stitches to keep the orientation of the button for the most part.
Hold it there so I can fix this up so we don't have to cut it later. Let me grab that. Yeah, yeah. Let me go through there.
You have that little branch there.
Yeah, I see that.
It's just,
Okay, that's good.
all right.
We can start with that.
Tiene los puntos para el.
Okay, you wanna put a stitch on that?
Yeah, just you put it now here.
I did. Is that a valve suture?
Yeah, esa es la sutura valvular, ¿verdad? De
Oh, we
complete.
need the sizer.
Los sizers.
Yeah, yeah. So we need the sizer with that's like this. We go like that. Size.
Medidor. Number?
For the connect, right?
Yes.
Connect, probably 30 or 29, I mean, 27. 27, 25.
Está uno, pone uno aquí. Deme otro.
Yeah, yeah.
You want the-
¿Puedo pasar la sonda 25?
No, pues pásala. No pasa nada. Sí, bueno, no, pues espérate un poquito si quieres. 25. 25.
Perfect. Anything?
I just want to put the sticks, probably you would change them.
What's that?
De 22, 22.
Here? Okay, here?
Yeah, I think 25.
25. Connect.
Perfect.
Ajá. El connect con una válvula 25. Ajá. El 20, es 3 milímetros más. Entonces debe ser 28.
¿Qué otra? The general, you don't use them. Except on roots. Okay.
Otro.
Sí, por favor.
Okay, we're putting the 3 commissure stitches in first, guys, and then we're gonna put in the rest of the stitches. Probably end up with 15 or so. Okay. Good. All right.
Otro.
Un tercero.
Stuck on something there.
¿Quieren que le siga dando continua?
Si se puede, sí, a ver si sale, a ver si funciona. A ver si funciona.
Te lo voy a estar dando.
Espera un rato, Diego.
Sí, todo.
Es que no está conectado.
Es que son tres tibones, 3 ox, 2, 3. Ok. Un poquito más delgado. Pero está bueno. No, está bueno, está bueno. Es very good.
Ay, yo uso el 3-0.
Porque
Cadena para el perro también se puede poner.
¿No?
Okay. These guys.
Forehand. Corta. Just somewhere around here. I'm just gonna go for the two.
You got it. Yeah, two, that's good. Yeah, that's good. Make sure you leave it in the tissue.
Yeah, just, one
Yeah, give
more.
one more after that, yeah, so we have four. Make it even.
It's behind this.
Well, it's caught on.
Otro.
¿Cuántos puntos vamos, Cindy? ¿Listo?
The importance here is got, you gotta be perpendicular always to the tissue. So. Like always.
We're leaving a rim of aorta that we're gonna oversew with a second layer around the root, just as a hemostatic maneuver.
Otro punto. Legal.
No,
Steeper.
How you guys doing?
Oh, I just put on stitches after Adams around it.
it was a very abnormal looking aorta. Really weird.
Oh, I think you guys are doing it then.
Yeah.
That's a
You convince
You
us.
talked us into it this morning.
That's exactly what the patient needs. It's a no nonsense. I call it
Common sense, yeah.
Yeah, I call it the no nonsense mental. Exactly. It's like, when everybody starts talking about all this other stuff, I'm like, yeah, no nonsense.
Where you ended up doing that on Adams?
Oh, we've got a bunch of restricted cords remodeled, the posterior leaflet put in there.
Whoop, you can just go that way.
Okay,
I'm good.
Very good.
We got it right.
What did you do to the posterior leaflet?
We cut out restricted cords at the margin and then remodeled, created a better surface. We thought.
Uno más.
It was kind of, not really wild.
But you see, you guys mentioned that the annulus in the T was 22. Here's some, you can put a 25.
Easily
This is
25. We could have got a 27 if we wanted.
It's really good. Not bad.
How about your next patient's already asleep? Sitting over
Buddy,
there already?
believe me, this place has made a big comeback. Are you kidding me? I gotta fill that auditorium up sometime this fall and do 8 of these things. And we'll advertise it all over South America and you'll have to stop. How many people can come?
What do we got? We got 3 marks?
How many stitches we have?
1,
Like,
2, 3. There's 3. We
So
got 15.
you want to do it in your way with a bucket here, or
Yeah.
okay? Sounds good.
Well, we don't have to
Oh,
cut.
you're gonna cut them. Okay.
Well,
¿Cortas, corto?
I go this back.
Portas, portas.
Yeah, why don't you get the needle, short nail holder? Go here.
How did the aortic look like?
You got a needle?
Yeah, it's retracted and no tissue. Just a geometric heights. Give me the
Thing to pass. it
geometric
over.
house. They're probably not even close to 14. They were like really bad.
There we go.
And
Expand that. Wait, these are the.
yeah, the comments. Yeah. I always remember Dr. Adams telling me about perpendicular to the tissue always.
Good. Oh, no, it's coming cross. Yeah. Good.
Yeah, let's.
Well, I gotta snap them again. I'm
There's
only,
not-
it says we don't have our person over there, so. Don't take.
I gotta hold on a second. Even this. I just. Say,
Yeah.
yes.
So Mark, you mentioned you're gonna do a second hemostatic layer. Is that with proline, and do you always do that?
It's gonna be with a large needle proline. Sometimes there's not enough room to do it, but,
Let me see. It's
I think, if you've got enough aortic tissue, it's, I don't know, maybe it's a belt and suspenders approach, extra secure. The first person I heard it from was Hartsel Chap, that he did it at the Mayo Clinic on all of his roots.
Pon el otro.
Yeah, good, good, good. Okay.
Lo clap aquí. Luego ya. Ir entrando en ritmo.
Forehand?
Forehand. You get a little bit more soft here.
Good, good.
A veces, sometimes the cuff, I think you get a little bit more comfortable, a little bit more. A veces, when you tie it, sometimes it can rupture, and then it's not, I don't know, it's just.
Oh, yeah, you got it.
Este es suyo. That's the question.
Yes.
All right. So how many we have?
This is the commentary. We got 15. So 4 in between commentary.
Yeah. Perfecto.
Okay, now we got
Yeah,
4 in here.
No sé. Forehand.
On the floor. I don't know, it's a little wide. No, a little less.
Less, like here.
Yeah.
That's good.
Because we have 4. 1, 2, 3, 4.
Okay, I got here. So you wanna do the other ones? Backhanded from there?
No, yeah.
That's fine. I'm just gonna do it.
Now I got all of it. Yeah, right at that.
See how it's going to the cuff here, like that.
Halfway. Yeah, good. Good, good. Very good.
Sorry.
You gotta.
You more before the commentary. Yeah. This is them.
¿Ustedes lo posicionan también de esta manera o lo hacen al revés, empezando con el izquierdo derecho cuando ponen los puntos? Igual. Okay.
Good, good. That's good.
How many more we have?
This is the commentary, and then we got 4.
All right.
Good. You do. Good.
Thanks.
Good. Hold on.
Yo agarro este y tú agarras este. Y que va. El que avanza. Sí, ese es más fácil. Ese es el punto del fellow. ¿Qué año eres de residencia?
Cuarto.
¿Cuarto? ¿Qué vas a hacer cuando termines?
Congénitos. Voy a empezar en más.
¿Aquí mismo? Perfecto. ¿No le gustan los niños? Sí, me gustaban, pero el negocio está muy malo allá en Estados Unidos.
¿Para congénitos?
Aquí también. Sí, there's no jobs.
No, no.
Es congenital, you just right out.
Erika, ¿me avisan para la continua?
Si quieres, I want this one and they just put 400 in between. Sí, dale. Te voy a dar ahorita le vamos a dar un poquito a los botones, ¿ok?
Va a ser directo.
Entonces por la izquierda.
Sí.
¿No tienen cornuts?
Sí hay,
Yeah.
pero
Ah, no, quédenselos, aquí los atamos, los atamos.
Yeah.
Este por acá. Este de acá. Este de aquí, mira, este es William Tell. Hold on, there is a William Tell here.
Where?
There is a William Tell.
Yeah.
Un
I
knife.
see it. I see it.
Una chiquito. Es que se entrelazaron.
aquí te voy a
You
colocar.
have a bucket. You have, how do you say bucket?
Bucket, I forgot.
Spanish.
Yeah, my Spanish is terrible.
Getting lame. Te las voy poniendo aquí, ¿vale?
Mark, can you hear me here?
What's that? You help? Yeah.
Just to pull the other one so I don't cut the switch for you.
You got it. Yeah. Okay.
That's it. It's good. That's safe. There's another one. Hold on. Está en otro aquí, hold on.
Okay.
Quedó bien aquí, quedó bien aquí. Hold on, we gotta.
What do you guys got on?
It's all twisted here.
Yeah. Yeah, these two are, yeah.
That's good.
There we go. We need to
It's
get
time
the
to tie.
needles off. Well, let's get the needles off first. One I have to deal with that. Needles? No, we're not.
No, no, we're not. Just tied.
Go for it. No, we're not. We're not the best. That's.
En cada uno, ¿no?
Well, no.
Córtalos, que te quedan unos si quieres. ¿Cuánto le atan ustedes? ¿8, 9, 10, 6?
6 a 8,
Seis.
6 and 8.
Yeah, yeah, six. Okay. Six. Yeah, okay. Okay,
One for the road.
be careful there. That's the one that's,
Yeah,
stuck.
broken, so.
Yeah, this could be, yeah.
Le ponen, hacen 6 nudos.
Con el forno, they just, we'll be done by now. Nah, it's not true. One more.
Make sure that one pulls up. It wasn't, okay.
Yeah, the plate has to be out, like a kind of outside.
Sección.
The basic? Yeah.
Put the plate down. Yeah, this is very important because you put the plate down, but it leaks.
You've got to evert.
Evert. You're gonna evert.
Let me pull up on that.
Oh, nothing. Yeah, just.
Okay, there we go. That'll
We're good?
hurt. Yeah, I think so. That's good.
Y luego nos va a dar una sutura tres ceros larga para ponerle una sutura alrededor del tejido que tiene aquí.
Medicine ball?
Medicine ball? No.
Let me put this out of the way. I'm
One more.
getting dysfunctional.
Yeah. Once we tie it, we're gonna give it some antigrade, okay, Carolina? Once you just to. You wanna tie those or?
Yeah, sure. Have a squirt head. It's looking beautifully.
Mm-hmm. This is what you want to see, right? The eversion, the plate outside. If you see it inside, because sometimes if you don't pull it, you will be leaking. You have some bleeding there, so that's probably key. Here, so 1 second, let me see that. I can pull the other one. You good? Yes, this eversion. Yeah, the assistant has pulled and revert this one, so you can.
Okay.
I think I've had one of these in like
Yeah,
5 years. Okay.
yeah, it's all corn nuts. You get cornotized.
O sea, sí, pero no lo habíamos pedido. Pero sí se ¿Meten?
We can take it out of the folder. And, suturar alrededor.
Siempre suturan alrededor.
It saves you. Te salva, me ha salvado de muchos sangrados. Si pones, lo ponemos profiláctico, ¿me entiendes? Entonces, it's completely dry. You don't have to, when you come out of pump, it's just ready to put them in the ICU. But sometimes you have, I don't think we need to any too much tissue there, but you know, we can bring something.
Yeah, there's not too much back here.
Knife.
What's up? Yep. And mess. I'll just get it short anyway.
Coming around there, I'll probably share. ¿Tienes las cariplegias, las cánulas?
Las cánulas de
Yeah, you're gonna give some cariplegia.
Yeah, okay.
All right.
¿Las Spencer?
Dale aquí a la izquierda un poquito, por favor. Go to the left.
Tienen en la mano y sí. ¿Le puedes dar igual a la retrógrada? Dieguito. ¿Puedes darle a la
A las
retrógrada?
dos,
Diego, 50 a 50. Solo está dando una, la retrógrada.
¿No está pensada la otra? Dale aquí un poquito nada más. ¿Cuánto le dice aquí? ¿300? Estoy pasando 100. Yeah, give me 300 and I just do that.
Do we get the other one? Or?
Yeah, they don't, because you know, they're using the
Oh, they're using one bag.
pressure bag by the resident.
Perfect.
Well,
I guess asking what.
I was telling Mark that we were in Morocco and you know, you think sometimes you just, a veces piensas que está en la necesidad. Allá el anestesiólogo hace todo, el anestesiólogo es el perfusionista y él hace o sea, no, el perfusionista es el anestesiólogo.
Ah.
Y le dice, hey, come down to the floors. Y va para allá y le mueve y sale.
Ah, sí, está dando.
Ok, dale, pónsela ahí.
Ya, ¿no dieron blush?
Tienes que metérsela ahí.
Okay, good. Está bien. How much more on that?
300 en la izquierda o no? Sí. Ok.
30, proline?
3-0.
30 proline.
3-0.
3-0. Yeah, 3. I'll go as soon as you're done. You're in my way.
You done?
It looks like blood's coming out now.
Yeah, no, it's pretty good. No, estás fuera. Okay.
No, that's the left atrium, you know. We don't want to throw that on there.
No. Maybe just half, you know, just half a hand. You can get some tissue there.
Yeah, I think so. I can get a little bit down there.
This one. This.
Yeah, I have. Tissue, right. But I need to go out of my way. I can't turn my needle.
All right. Para la izquierda. Up.
Can you hold that up?
Yeah.
Yeah, good. Oh, something like this. Hold on. Let's tie it. That way we won't need to go around all the way if we don't want to. Oh, good. First, yeah.
La tuya sigue pasando, ¿eh?
Sí, ya párala también si quieres.
Okay, yeah, this is our I don't know, partial shaft stitch, we'll call it. Just gotta get the first one in.
Yeah. And it works. Funciona la dirección de aquí a acá. Si lo tratas de poner de aquí para allá, no funciona. O sea, bueno, sí funciona, pero es más difícil. Sí. So you gotta have from the fuera de. ¿Y de rutina lo hace? Sí. And if you're really, really concerned, you put some bioglue there. That just.
This looked like pretty good tissue, though. I'm not really overly concerned about leaks here. Let's get to this.
Superficial.
Oh, there we go. That's aorta back there.
One time I was doing one of these and I passed the suture through here.
Through the valve?
And not through the tying suture, just with the sharp, it cut the suture. So you got.
Yeah.
Que está ventricular.
No lo hacemos de rutina. Alfonso de rutina, no te vas a arrepentir, te lo juro. Lo mismo aquí los ponemos de adentro hacia afuera.
Ajá. Anterior ventriculares, ¿no? Nosotros lo hacemos
Here, why don't you
ventriculares.
take it forehand and that way?
Yeah, just.
¿Tienen otra pregunta?
Sí. What is the question?
Mark, did you put that 3/0 through the graft or through the sewing ring?
Through the sewing ring. Yeah, I mean, you could put it through the graft, but there's not really much bleeding up by where we did the knots. What we're worried about is bleeding out down by the felts. I think, where there's where it's the root. We don't have enough aorta really to go up to the graft either. So much. Underneath the left main, we almost had none for a couple of bites.
Thank you.
Thank you. Do they have an eye clottery?
Yeah. These ones you can take big bites. You don't need to be so dogmatic about just small bites. You just run it and bring some tissue in.
But try not to get the RV though.
Yeah.
Neil,
Needles already. The needles give up.
I can bring it.
Yeah, bring the other one.
Side.
That's it.
Yeah,
It's done.
all right.
Over here?
You're gonna just shot. You got another new one, and you just can.
No, I can run it.
Just.
Oh, I can go like
You gotta.
Sure.
It's gotta be a little short, but
It will be. May or may not reach.
we'll see. You can put another one. You're gonna have to. You gotta pull this off.
Yeah, I'm just gonna let it dangle. Whoop, no, you got the stitch.
Hold on a second. I'm gonna give it.
Actually, I'm good.
Yeah, maybe you would. ¿Y tiene un cauterio para el botón?
I might try the other way.
No, solo voy a no tenemos de inverno.
Nomás lo abre con la
Listo.
bisturí. Ok. Sí.
Quemamos con esto un poquito.
Ruby. Ok. For the one.
Antes en el
This is for Abe. We're doing a little bit of left-handed. Just throwing it in extra ends. He's left-handed too. I think, if I remember.
Really? Okay.
I think he's left-handed. We'll have to find out.
You gotta ask him. One more. No, it's gonna break.
Yeah, let me get one more bite.
Si no, no se preocupe, ahorita le abrimos aquí. Hacemos un agujero.
Okay. Cut that.
All right, so we see who's gonna tie this. You just,
Yeah, something with very small.
no, keep that one here.
Solución.
Cut that.
No, para
No.
tayo, I'm gonna, que me alcance.
Put them up. Excellent.
Okay.
You have, eye cautery, burn? No, how do you cut the scissors? Oh, blade, okay. They don't have an eye cautery. Oh, good.
No.
Y mañana lo mismo, the same thing with circle race.
Are we doing a route tomorrow? I don't remember.
Yeah, root and you gotta put it up. It would reach.
Blade, knife.
You're gonna do the left first?
Well, I'm just gonna make both buttons.
Okay, sounds good.
You know, test them, do you? I mean, that's for. Yeah, we will do the left first. How do you think we cut it? With the blade? I've never done it without an eye cautery, have you?
Oh, no, you see that blade? It's like a scimitar. That's
Yeah,
fantastic. You never had this one before.
Oh, yeah.
Like a scimitarra.
A bit bigger than that.
Very nice knife.
It is.
Maybe I'll take a couple of those with me. See you.
Let me, come this way. Yeah. Yeah. That's good.
That's good. No burning. That's pretty good.
That's great.
Look at this one here.
Left button now.
He was rich, yeah. Hold on a second. Deme un 4-0 que tenga por ahí. ¿Tiene un 4-0? Un 3-0. Uno, pero más para referirlo, para jalar aquí el.
Coming through, can you see my blade?
Yeah, hold on a second. Hold on. Do it. Yeah, I see it.
Is it okay?
It's okay.
Work around there?
It's okay. You just don't go too deep because the valve is.
Okay.
What is it?
Oh, I see the
dolphin. Beautiful knife. Really, we don't have this over there. Bigger?
A little bit. I want to get rid of the knot. You know,
Yeah. 4 5 5-0.
Uno, dos,
5-0.
tres, cuatro, cinco. Cinco.
¿Está bien tanto viejo o por ejemplo?
Yeah, whatever he wants.
¿Protegida?
That's an
You gotta
RP.
go from that side, you said, or?
Yeah. And then,
Yeah, 400.
yeah,
Good.
and then, yeah, usually this side, more hand. For the left button from this side and for the right button from the other, from your side of the table. That's gonna be right about there. Huh?
So, aquí no sé cómo ustedes lo hacen, pero siempre tratamos de poner el punto más hacia la coronaria, ¿me entiendes? Te quitas todo el punto, no aquí, casi adentro.
Pero sí le dejan como el borde.
El borde, pero fíjate las mordidas donde van hasta casi hasta el óseo de la coronaria. Y eso es porque que se pueden quinquear, se pueden torcer. So este pequeño, ¿se puede poner el succionador ahí? Puedes, luego la software. ¿Este paciente estaba en AFib o no?
I think so. It didn't look like this. I think that's the other guy.
A ver, dame ese. You see, los puntos hasta casi adentro del osteo. No los haces aquí, los haces aquí.
Relax a little bit. Can you relax it?
Yeah.
Yeah. Yeah. Good.
Y la atención siempre es lo más importante. Creo que cuando le ayudaba a Coselli, siempre se enoja porque no le sigues estudiando.
Ah, ya. Contención.
He gets cranky if you don't follow such a you're inside. You're inside there. That's I'm okay here. Yeah, you're good. Yeah, you're good. You're good. Yeah, you're just.
¿Les ponen alguna vez refuerzos de rondana? Eso de que
Dependiendo. Aunque la verdad es que no. This is what suture is. It will last. Unless you maybe Marfanes or Lois Dietz or.
Ah, ok, ok, pequeños tejidos primarios. Okay.
Let's hold that for a second.
All right.
And that's,
You gonna come with this one too?
wait, cut the top off.
Ah, good.
Pretty thin out.
Oh, it's beautiful.
You got it? Thank you. All right.
Hola.
This is a beautiful meal all the way around.
Yeah, right. Castro.
I mean, it's a beautiful Castro. It's not broken like ours.
Oh, boy. ¿Tú lo sacas de compra? ¿O es lo que se Hold on.
Yeah, yes.
Hold on.
Mark, do you ever use the felt donut that New Cameron described?
Around on the buttons. No, I haven't. I think, we just be extra careful in those type of Marfan patients or Loeys Dietz. That button's a problem on a redo, and I don't know, I haven't found it too helpful. I don't know what you guys think of it. We'll find out. Roscoe,
Well, yeah.
Ellie use it button number?
Coselli, puts up in Marfan or Lois Dietz. That's the only thing that you might consider to put it in, but I think that's it. For dissections, when you gotta do a ventricle, put a strip of pericardium, but that's pretty much.
Okay. Why don't you bring these last guys?
Yeah. This one over here.
That's some boss. Let me get this corner out of here. Don't move your stitch. Okay.
You got a little bit of back here.
Okay.
Maybe you reinforce this corner because I think you want to pressurize the root and
well, we can. I put a hole on the other side.
Yeah.
We can pressurize it once they're both done.
Yeah.
Here. Let me see if I can get there.
Yeah, get that.
Oh, yeah, I think I got it.
You got it? Yeah. You will come down.
One more. Let me get one more.
Yeah.
Man.
I'm gonna do it backhanded here. You might want to put up the picture soon.
Oh, yeah.
6-0 o 5-0, whatever. Me da otro simple 5 ceros, por favor. You want to use some felt for this one or just
yeah,
right?
Yeah, let's.
Vamos a necesitar si tiene un pedacito de felt de tuna. Yeah, I think I should put one.
Yeah, it's not normal.
Oh.
Okay. 5-0. Another straight single.
5 ceros.
What's that mean?
Cero is yeah. Oh, it's cero. Yeah. I think in US it would be 5-0.
5-0.
Just a 5-0, but
We put a couple of bites.
yeah. That looks more funky.
I mean, on the inside, it may just be perfect, but on the outside, it looks pretty gross. Yeah, let's see.
No, it's just, this is the.
What, did I have the wrong one?
Yeah, this is the.
Got it. Okay.
Yours is
Yeah,
here.
yeah, yeah. Good. Let me run it up to there too. Why not? Keep going. I'm gonna go up to this. I'll bring it back.
Yeah.
Siempre dan doble línea de sutura o dependiendo.
No, dependiendo, a veces se reforza la parte posterior con problemas de 6. Después en la parte, en la cara posterior, si ves que tiene orejas de perro, entonces le pones ahí sí, la sangre, las tienes que reforzar bien. A ver, échame un poquito de agüita porque estoy seco aquí como.
Oh,
All right, let's go to the right.
all right. 5-0.
5-0. Well, that little branch is just.
You're gonna say that. You'll be all right.
Hopefully.
Well, you're gonna put your bite right into it.
Deme otros 5. Otros 5 ceros, ¿no?
Yeah, go inside out here first.
¿Empresas también a protegidas?
No, ya, yo creo que ya estoy. Solo tenlo listo.
You as well.
Todd? One of these?
Let me get a little bit more material.
Okay. Now inside out. Kind of right at that, right above that branch.
You're gonna save this one. I don't know if it's worth it or not, but
We're gonna save it anyway.
if it's possible.
Maybe don't pull.
No, we're gonna put here.
Go to the second bite. Hang, yank it. We'll first drink a few. Let him dissect the flap right at that stupid.
No.
Oh, I stepped flip it.
Hold on. Corner is confirmed.
Yeah. Boy. Wait. Okay. I'm just trying to not fall on the floor. A little more cornering, I think. A little less grass. Let's pull it up.
Yeah, put it up. You gotta put more graph money.
Yeah.
Give me come out.
Yeah. Blade, we had that,
This way?
okay, hold steady, huh? I don't back yet. Let me just go up here. Do that.
una de Baker vascular.
Can you grab that? Good. How do I do that backside? I need to get back off. That's gonna be big enough.
You got a trim here.
Oh, yeah, yeah. That's a bum.
Pues no tienes que tener mucho tejido, más chiquitito. Suficiente. Yeah, suficiente. Give me that. This is the best cast that I ever have in a long time.
Outside in.
One second.
I'll follow from the inside right here. Pull that up and I will follow here. Yeah, isn't it? That's a great catch. Just go, yeah, on the half.
There's one more.
I'm a full bite, I mean.
Y luego está todo sticky.
¿Otro Castro?
No. Mi guante está.
I come out there and come with the other guy.
Yeah, I'm gonna come on. Ya está como, ahorita agarro hielo, no sé, pero tuviera un poquito de hielo. Agüita.
Okay, good. No. Hey, we're. Yep.
This branch is, I don't know if it's worth to preserve. What do you call that branch? Is this?
Well, if it was big and went to the LED, it'd be the conus branch. But it's nothing.
You want to open them more, or we're good?
No, just you can. I don't think so. It's pretty wide still. You can just travel the artery a little bit more. Yeah, that's good.
Voy a mentir aquí un poquito. Mentiroso. La presión de 100, ay, güey.
Esta presión es.
Yeah, get deep in there.
Está muy alta la presión.
Ayúdame a bajar un poquito. No, para conmigo, por favor.
Let's get one more there.
Couple more. Why don't you get it the other way?
Yeah, sure.
Then I can probably take it in. Like, not that guy, the other guy.
It's beautiful inside.
Yeah.
Pues aquí, ya lo sabes, cuando te quedas un poquito para evitar la oreja de perro, nomás viajas mucho en la arteria y te regresas al injerto en la parte de atrás. Entonces, con eso ya no tienes que hacer el agujero más grande, porque luego los botones también grandes hacen aneurisma. Los hizo muy pequeñitos. Sí.
Sí.
We're gonna test them. We're gonna put some cartilage here.
Very good.
Vamos a darle cartilage, pero va a ser una presión para presurizar el.
Okay. Yeah.
Dale, llena.
Yep. Go.
Llena el. Clamp.
Yeah, clamp. Like
Tiene un
clamp. Clamp. This is good. That's good. Yeah. Kelly. More?
Sí, ya
Keep
sé.
going.
Dale. Vamos a presurizar
Here, can you help?
pick up
Or
this.
hold this and I'll get 4-7. 4-7. Yeah, go, good. Yeah, go.
Dale,
¿Tienes otra?
la máxima presión que puedas darle.
If you guys can hear us, we're testing the coronaries. It's very good pressure here. Don't see anything coming out around the right. Nothing coming out around the left. I don't think. There's a little flap right here.
You gotta tack it.
Okay.
You gotta put a 6
It's
salt.
not leaking.
All right, so, but,
Okay,
Bueno.
good. Bueno. Okay.
sí, sir.
Medicine?
Ya empieza a recalentar, pacientes. Start warming. Let me take this out for a little bit. I think it just,
Well,
whatever's gonna be.
All right. Okay, yeah, but might as well leave it. We put it in. Although we don't really need it. We can de-air
Here with a needle and then just, or,
needle and also we got an LV there.
yeah.
So, okay, let's take it out.
Vamos a quitar
Right
este.
to here. Yeah, I got that. We'll go right to it.
Oh, no, just got it.
No.
You want to readjust the clamp?
No, that's about as good as it's gonna
It's gonna
get.
get, okay. ¿Tiene la cosa de playet?
¿Los teflones? Sí, por favor.
Está bien.
Yeah.
This is good. This is great.
Okay. Oh,
También un 3 ceros.
3 ceros. Por favor.
Río. ¿Quieres venir a superar este o qué?
Sí, puedes.
All right, come over here. I want to saturate.
well, you're she.
Sport.
Okay.
She's ready to do it.
Okay.
Ya pasa allá. Okay. Órale.
Okay.
Just follow, just out.
We're table.
Okay. Mira, el punto. Vas a empezar. Inside out. Into the-
Here. No. Okay. Okay. Real?
Tómale una foto también, oiga, para que no se les...
Erika,
No se va a ver, Eriquita.
Ahora, Eriquita, dale. La foto, Eriquita, que se vea bien. We're almost done.
Right. Primero la otra. Yeah. How big? No big. No bigger. Yeah. And what? In here. Yep. And careful. Up. Careful. Up. Is this longer?
Tienes una referencia, un mosquito o algo. It's not shot, it's gonna...
It's a okay, here you go. Lower. Forehand.
Aquí con la mano vas a ir adentro del injerto y luego en la...
You know. Here. Yeah, 3. Trace.
Y luego tres pliegues. Y luego de afuera hacia adentro, cerca del otro, pero agarra playa.
Big bite. Yeah.
That's it.
Let go.
You gotta do like that. Put it like that and you're done. So we're here. ¿En cuánto está el tiempo de pensamiento ahorita? 68. It's good.
Okay.
Me están comentando que me parece que moviéndose se ríe un poquito la cámara del doctor.
Your camera is out of sight, so.
Okay, yeah. Can you fix it?
I don't know. ¿Me da otro guante?
No, close.
Yeah, let me. Le voy a mover la cámara nomás para.
How do you say not far?
No lejos. No tan lejos.
You gotta tell him to go perpendicular.
Tienes que ir perpendicular. A ver, no.
The radio.
No.
Yeah.
Estamos hablando. Agarra la.
Over what not, how not to angle it and how to angle it.
Cuando vienes aquí, no tienes que hacer, no viene así, la pinza no viene así, tienes que ser perpendicular al tejido. ¿Entiendes? Aquí.
Right here, a little closer though.
Like this. Sí.
Okay, okay.
Okay. Do it like that. Perpendicular. Okay.
Oh, no.
A ver.
Only needle. Okay, go. Yep.
I'm gonna let me wear.
Bigger. Yeah, yeah.
Okay. Ahí está bien? Okay, good.
Thank you. We good now?
Yeah, you're good. Vamos cerquita. Cerquita. Se va a.
I'm gonna see if we can do it one by my. Okay.
Sí. Este tipo de pensamiento se va a ir para arriba.
Okay, drop.
Yeah, you just, the resident is doing the proximal anastomosis.
The coronary, you mean?
No, the ascending. We're gonna put it back up. Yeah, the graph is
Okay.
yeah, it's- looks pretty good.
Yeah.
¿Pueden escuchar allá? ¿Están escuchando lo que estamos hablando aquí en abajo o no? Can they listen what we're talking about down there o no? Digo, la gente que está en el auditorio puede escuchar lo que decimos aquí en el quirófano o no? I don't know, but you never know. Okay.
Yeah. Can they or not? No idea.
Yeah, they can listen. Cerquita. Let's go.
Not far. Very close. Dice close.
Cerca. Cerca.
Okay.
No.
Mañana que pensar igual. No, pues mañana es Alma Rosa, Daniel, los de jornada.
Los injertos, eso nos ponemos en rifampicina casi todos. Todos los injertos ponemos rifampicina todos. Casi. ¿Mm? 80 miligramos los diluyes en agua.
Cantidad para que cubra.
Para que cubra el injerto y todos. Y eso nos ha ayudado. Pero tienes que dejar unos 10, 15 minutos para que realmente se impregne. Entonces, cualquier injerto que pongamos en rifampicina. Entonces, a lo mejor se puede ayudar un poquito.
We're getting there.
You getting there? All right. She's moving along.
Good job.
Pero sí le informaron a los jefes de impregnar
Oh, yeah.
la rifampicina para.
Sí, no, eso digo, para el futuro, si lo quieren hacer, es una práctica que nosotros hacemos en todos los pacientes.
Esos tips son los que necesitamos aquí.
Sí, los impregnas y todo. Si es uno de 8 milímetros, que sea, todos van impregnados. It's a big bite and this.
Yeah, but something, see if they can get us a couple felted stitches, like this.
Yeah. Me da unos, what do you want it, like inside? Yeah, doesn't matter.
Like a 4.
Me da un 4 con papel. Ah,
No importa el tamaño de la aguja.
no, no importa, no. Yeah.
¿4?
Or should we just use these? This is a felt.
What?
Do they have?
No, they're gonna give it to you. They're gonna give it to you. What do you want to reinforce it? Inside out?
Well,
Outside?
like, yeah, there's right
Yeah, I
here.
could put some from the outside.
I think I better
Inside?
put one
Okay.
inside right there.
Yeah, I got it.
Okay. Well, you wanna, yeah.
Yeah, okay, let me take over here. So just,
Okay.
a ver, aquí la pasta extra. A ver. Cuatro?
Yeah, man. I'll get it four-handed. But
Yeah, okay, sounds good.
yeah. Let's see here.
Yeah, it's just one. Es que se puede, ¿cómo está?
¿O no? Fecha,
Si no, por fuera.
en cuanto la pusieron, ya la.
Y honestamente, it doesn't make a difference if you put it inside to the plate. Plates pueden estar adentro de la horta sin ningún problema.
Be careful. Gotta get way over here. Relax it. I gotta pull it down. Yeah, let me go farther. There we go.
Sí, eso es lo que pasa con la cuando tienes que tener perpendicular.
I don't
¿Entiendes?
think I need a felt on
Ah.
that this side.
Si no tienes desgarros y luego tienes una disección tipo A, pues,
No tienes el ya te puedes poner.
tienes que practicar los ángulos.
Sí, sí, por supuesto.
And then there's a gap right there. I need
Yeah,
a
we can
pour
put on-
with no, we
Otro,
don't need a.
otro sin play it.
Okay. Yeah, do you have that question? Yeah.
Cuatro.
Thanks.
Thanks. Perfect.
Bueno. What's up?
Y tiene una aguja de esas rositas de las pesadas de las que tiene buena, que es 18, que tiene 19.
Aquí está.
No, al final me la da. Ahorita le digo para
Okay.
el de-airing.
Needle holder?
You want to come with the other one, with that one, or?
Yeah, this one, I think.
All right, you do it.
El porno, ¿caso?
Fíjate. Tienes que seguir la curvatura de la aguja.
This is like that's a MH needle.
Yeah, they just,
That's big.
it's good.
Toman tres.
Tres.
Ajá, ok.
You can double bite the graft and it will go inside the aorta. Follow? Sure. Sí, te dejo que abra. Ahorita ya vamos a quitar el clamp ahorita en unos segundos. Sí,
You wanna shut up LV then? Fill up it. Take
Yeah.
air out.
Apágale el vent, por favor. Shut down the vent.
El vento.
We can clamp it.
For more.
Yeah, that's like- yeah. Here, one more bite. Yeah. Head down. Can I do that?
I can do it. Ya tenemos la hojita roja.
Yeah, yeah, yeah.
No, que ya no saben, pero ellos dicen que hay aquí, allá. Pero es la misma solución, ¿eh? Solo dice que muchas veces la
I'd refill the heart with blood.
Yeah. I have a 19 gauge needle, so you can give it so you can, bend it.
It'd
if
be
you
nice
want.
to get a lot of that.
Yeah. You want to bend it right now or just?
Well, we could,
Can you fill the heart, please?
Phil, blood.
Llena el corazón, llénalo. Dale unas buenas ventiladas. Unas buenas ventiladas. Son ventilations.
We're done blood, that means heart blood, right?
Yeah. Dale una.
Well, that's, I don't.
Llénalo. Dale volumen. Pínsale. Ahí está. Okay. Apaga. You can.
Yeah.
Yeah. Please, okay,
Now
we
we're
just tried.
getting better. Hold on one second.
Llénalo. Dale unas ventilaciones.
Vamos a ver.
No, well, we're just not gonna get.
No sé, you're not gonna get the whole thing.
Successful. Okay, whatever. Okay.
Ok, deme ahorita la. ¿Ya la tienes? Por aquí. Córtale.
Now they're full.
Ya, te quita el volumen ahorita.
On.
Pon el número 3 de nuevo.
Yeah. Okay, bueno.
Ya está.
Ok, hold on a second. Give me the 19 gauge needle.
19 gauge, needle.
La,
Oh, you got it. No, good.
Por acá.
Empty? Okay, blood, no blood.
Y déjeme la
No,
tapita
blood.
de una jeringa de 13 cc tiene, me puede dar nada más
¿Puedes bajar la cabecita?
¿Qué quieres? ¿La aguja?
la aguja?
sí.
No, la
El de tres. El embudo.
el émbolo. Bueno, lo que mide.
No,
De la jeringa nada más.
Ahorita le digo para qué. Quita el volumen. Empty the heart, empty. Vacíalo.
I think he's in.
Aquí hay una
Are you done?
No, pero no, deme nada más la pura, el émbolo
El embudo de la jeringa.
de la jeringa hecho. Ahorita le digo para qué.
No quieres.
Mire, aquí se lo ponemos aquí así. Entonces, when you start injecting, you just don't the squirt.
Are you done tying this?
Yeah, está, but there's only one stitch here. Sí, se lo controlas aquí. Tiene que estar aquí. Se lo dejas aquí así.
Le colocamos a nivel del injerto, pero luego sangra mucho.
Already here.
Trío.
Injerto.
Tiene un poro. Tiene cuatro.
Sí.
Ya se puede olvidar dentition, hematomas.
Yeah, probably that's it, with the budget.
Completo.
Me da otro completo. Otro nivel.
Tiene
You have a defibrillator?
desfibrilador.
Sí. Las balas, por favor.
Y lo tiene, you want to play it or?
Yeah, I was thinking, yeah, could have,
Yeah.
up here, yeah.
Ah,
I think we're okay. Oh, no.
¿Ya salió?
Okay.
Ya. Ok, nada más. Tiene una.
¿Cuatro ceros?
Sí, por favor.
You want to put it or you want to put it on here?
Why don't you do it? It's not beating backwards.
¿Tiene una aguja más grande que esto o no?
Make it wide.
No, una bigger needle. What do you think?
Ok, yo le pongo el peso. Un segundo.
Gracias.
¿Todavía no tiene el marcapasos?
No.
No.
Looks pretty good, not much bleeding. Just that little hematoma there.
You want to open it or?
No, I put this, I think it's from the needle bites.
Yeah.
So, you just put a.
Se lo ponemos.
Oh, yeah. What do we have?
¿Puedes poner los flujos bajos, por favor?
Bueno.
One, okay.
Electrónico.
Well, 1 minute.
¿Otro?
¿Otro cuatro o otro play?
No.
Pledge it?
El play.
Yeah.
Pues.
El electrón todavía no.
I think it's bleeding between the suturals, this one.
We'll need one more. Una más.
Cuatro. Play it, play it.
I got the pleasure.
Okay.
Got it.
Y otro más, ¿ok? Ya puedes poner otra vez los focos arriba otra vez. Un ratito, ¿ok? Nada más. Vamos a ir otra vez abajo.
Solución, por favor.
I think it's where the needle was. Something like that.
Yeah, I think one more towards you.
One more there. O tráeme otro igualito a ese. Al anterior. Ujú.
Mhm. I can get this one from this side.
You want that? Okay.
Yeah.
So I don't know if there's any other questions in the audience, and this is gonna win him out of the pump. And you want frozen or?
Yeah, I think that'll be all right.
No, okay.
Y otro más, ¿ok?
Ah, un cuadro, pero por favor. El cacho de la defensa. Otro cuatro peras de bola.
A ver, en desinfla de este si quieres, porque
Una jeringa.
Mucho mejor.
Oh, yeah, it's beautiful.
No, tengo.
¿Lo desinflaste? Ok, córtale aquí con eso.
¿Corte?
Okay. Here's, let me, oh, you got it there.
There you go, there.
Tengo el tercer cuadro.
No, sí, ahorita te lo dice. You want another photo or you're good?
Here?
Yeah, here.
Oh, there. No, I think we're good there.
Creo que ya estamos bien. I think we're good. Okay. Success, I guess. So far. Mira, ya le pone la tapita. ¿Dónde quedó la tapita? Quítame la tapita, ¿se cayó?
No, ¿tienes el émbolo? ¿Te lo devolvieron, Lili?
Aquí está el émbolo, en la puerta de abajo.
Ah, no, aquí está.
Tengo el émbolo.
Aquí está.
Are they breathing? Yes, they're breathing.
Y no me le pones, nomás le pones un programito y listo. You want to take this out? This thing is just nothing here.
Well, no, this looks good. No, yeah, it's okay. Just to look around. There. I think that's okay. Oh, yeah? Yeah.
Give me
that. Yeah. Maybe I'll let they go.
That looks pretty good.
Yeah, that's good. That's great.
All right.
Bueno. Matson
Métsenlo.
and Forsyth. Thank you. Gracias.
68, 79, 15. 86, 15.
We are too slow still.
Now what?
Yeah, they can. ¿Lo puedes sacar a bomba o quieres que nos quedemos? They can get him out of the pump. Yeah, they will do it.
¿Cuánto tiene de temperatura, amigo?
Descansar. ¿Cuántos minutos tuvo el pensamiento? 86. Usualmente le dejamos 10 minutos por cada hora de pensamientos, a lo mejor 15, 20 minutos que en lo que se reperfusa y luego ya lo sacas de bomba. ¿Ok? 10, 15 minutes.
We're going.
Yeah, picture. You're going to take a picture with us. So.
Oh, yeah.
Mándala, 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 gente.
Thank you. Gracias. Gracias, gracias.
Gracias. Seguramente no es nada que ustedes no hagan, ¿me entiendes? Nomás es para que vean que
Wow. No, lo que pues, bien, bien, gracias tú. Mm, mm. No, pero yo sí ya estoy mucho mejor, ¿no? O sea, Ah, pues sí, 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 sí. Ah, bien, porque faltaban, bueno, que faltaban 10, ¿no? Ah, 8. Mm, sí. Ah, ya.
Nos faltaban 8 del anterior y están pidiendo 4 del nuevo.
De lo nuevo ¿de qué? Ah, sí, 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 sí. Eh, sí, eh, sí. Bueno, ok. Y eh, sí, sí, ayer le dieron ahí el chaflán de toda la barda y y que hoy me dijo este muchacho que le iban a dar una pasada con cemento, sí, entendí como muy rebajado. Sí, exactamente. Pero sí, sí, no sé cómo habrá quedado eso. Eh, sí, pues ahora sí que tú, pues eres el que sabe de eso. Mm, y qué más, qué más. Pues sí, ya prácticamente. Sí, y también le dieron entre la teja y el muro, también ahí le sellaron.
Disculpe, tiene el micrófono prendido sin querer.
No te mandó, yo vi unas fotos, no sé si fueron fotos de él o tuyas, ¿no? ¿No? De ahí donde entre, ah, ah, sí, ahí. Ah, sí, es que iban a hacer a cambiar de todo el fraccionamiento, a hacer una revisión global. Mandaron, mandaron, por de la administración mandaron un mensaje que iban a hacer pues un chequeo general en todo el fraccionamiento, los de Telmex, y arreglar y dejar, porque había muchos problemas, y así como que iban a actualizar y hacer, pues una manita de gato a todo lo de Telmex. Sí, 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 exactamente. Sí, eh, sí, sí, eh, sí. Sí, sí, es que iban a hacer todo y que iba a ser medio programado por áreas diferentes, una área, otra, hasta terminar todo el fraccionamiento. Sí. Pero pues ellos son los que los mandan, los de Telmex.
Doctor Federico García Soriano tiene su micrófono prendido.
Habilitaré.
¿Y mi micrófono?
Sí, se activó.
¿Mande?
Ahí se activó su.
A- Aquí mismo. ¿Tendrá que estar prendido mi audio?
Pues es su audio.
Sí, es mi micrófono.
They're not playing the Zoom.
Yeah, he didn't even try to regret it.
What's he doing? He's doing a valve replacement.
Now it's open.
Okay, great. This is a mitral valve replacement
Oh, yeah.
with
Turn the
a
speaker off there.
magna valve.
Turn the speaker off up here. Okay.
Yes. As always, at a mitral and aortic valve replacement, you would want to place the mitral prosthesis before placing the aortic prosthesis. Placing the mitral prosthesis first ensures that you have the optimal visualization to get the mitral prosthesis well seated.
This is Dr. Moon. They're doing a mitral valve replacement in this patient who had the secondary functional tricuspid or mitral regurgitation. One of the findings that Dr. Adams had in the operating room was that the anterior leaflet and its cords were fibrotic and scarred. And he felt that a repair would not eliminate the regurgitation necessarily. And therefore, in this quite ill patient, he's trying to do a rapid mitral valve replacement, which now all the sutures are in. They've just got to tie them. Then they'll plan to close up the left atrium and then address the aortic valve. Dr. Gillenoff, you were part of that CTS-NET trial comparing mitral valve replacement with repair in ischemic MR. What were your takeaways from that?
That trial looked at people having surgery for severe ischemic MR. And the key takeaway that was that in most patients, a replacement was superior because those who got a repair with an undersized, complete, rigid or semi-rigid ring, those who got a repair had a great deal of recurrent MR, more heart failure events, and more deaths over 2 years. There were a few people who did well with repair. The challenge is we can't identify who they are in advance. Okay.
It's now open and they can hear you right now. The cam is on.
Oh, that's us. Okay.
Okay, great. There will be no leak, there will be no stenosis. So they need not worry about the mitral valve in a while as they try to come off bypass after replacing the mitral first and then the aortic second.
Sometimes it's helpful, especially in a redo with tissue valves in place or mechanical valves in place, to take, if you're going to redo both, take the aortic valve out first, because it makes it easier to pull over on the atrium to visualize the mitral valve. Is that your findings
Yes,
too?
yeah, that's a great point. Whenever there's an aortic prosthesis in place, mitral exposure is going to be compromised. Especially if you happen to have a mechanical aortic prosthesis, then it's very challenging. And having the mitral prosthesis in place, when you address the aortic valve, does make it a little hard to see the non-coronary area. That area is pulled down a bit, but it's not that bad. You think it's another case where they've used custodial?
No.
I think their custodial is their routine cardioplegia. Unless somebody's.
How long is custodial good for?
Custodial, I think we kind of discussed that, and the general thought is 90 minutes to maybe 120 minutes. When we used it upstairs for our root replacement, we just periodically gave a second dose when it was comfortable. Probably it was 45 minutes to an hour. After we had put the root in, we gave a dose.
It's massive. Okay,
Did you combine it with some topical ice slush, as we saw in the first case?
Yes, we had ice slush on the part as well.
And I saw that you were using a phrenic nerve protector for the left phrenic, or at least the mitral they did.
Yes. I don't usually use one, but I did have a patient when I was a fellow at the VA. We froze both of his phrenics, and he was with us for about 4 months with a trach until one day he could talk and pulled out his trach and went home.
Veterans are tough.
Coronat would be nice here.
Yeah, it would speed things along.
Started using it a lot more. Right? Not only does it make the case faster, stitches not to go down more uniformly, or automatically secured.
I have had one instance though where my assistant actually tore the coronat out. And unfortunately, the pledget was on the ventricular, was on the aortic valve, and it was near the end. So.
Disappointing.
Yes, yeah, that's a good.
Well, we had one faculty with the coronat. I don't know if it's lose control but you can't, when you're firing it, you have to keep it stationary.
Yeah.
Because it's like shooting a gun kind of. It's got ricochet forwards. And he stuck it right through the ventricular outflow tract. So you gotta be as everything we do in surgery, some of it seems so simple, but you have to be careful. Everything.
Yeah, there's little tolerance for any misstep.
That's for sure.
This is going in quickly. When you take the clamp off and you've used custodial, how does the heart come back?
We didn't have to shock. It sat kind of asystolic for a couple minutes, but then started to beat a little slow, and then sinus rhythm within 5 minutes.
That's similar to Del Nido.
Yeah, I think that custodial is along the same lines as Del Nido. We found though in thoracoabdominals that custodial is not good for kidney perfusion.
Really?
We've had much worse outcomes with renal function when we've used custodial. So we've actually, Caselli and Scott Lemaire did a randomized study years ago, comparing blood, normal thermic blood to cold. I forgot what solution was, but it wasn't custodial. It was probably lactated ringers. And found that the perfusion kidneys did better than the warm blood. But that was left heart bypass blood. So, and without an oxygenator.
Right.
So it wasn't oxygenated. So what we've done lately, since we weren't too happy with the custodial, is shifted to hyper oxygenated blood. So we've added an oxygenator to the left heart bypass circuit. And now are perfusing hyperoxygenated blood into the kidneys.
Yeah, I go with full bypass when I do those. And I give full blood to the viscera and kidneys. Find that protects me. I think left heart bypass has a few. Rewarming and oxygenating and all that stuff. You end up losing something. At the end of the day, you end up with a full cardiac bypass machine. So might as well just start with that.
Well, the benefit to it is that you don't have to give full hypertension, right? But yeah.
We're discussing heart surgery, so it's okay.
Yeah, that's what they say. You don't have to get full heparinization, but it's we probably over heparinizing.
Yeah, and you know, but one time if it's gonna be a very complex dissection, it's labs all over the place. I like to have the pump sucker. Pump bypass, because one thing we didn't do at WashU when I was there was use this rapid transfusion system. So we didn't want to lose blood. So we were either on pump, getting blood, or just weren't losing any. But Caselli's got this system. I mean, you can give back a liter a minute through this, I'll say, rapid transfuser. And the way that rapid transfuser was developed years ago, he told me, was that there was one of the hematologists, they kept ordering blood from the blood bank for these stored. And so, and the hematologist was like, you can't do it. So Caselli invited the hematologist down to the OR and watch a case. And that's what he said, we got to come up with some answer. So he came up with the rapid transfuser. Wonder what he's doing here. Is it?
¿Tienes un rollo en campo?
Like the same thing.
Yeah, probably not.
Okay, maybe something. Don't worry about it. We're very much open. Probably then.
Yeah, more. Checking the struts with the dental mirror to make sure none are entangled.
Yeah, you know, the mitris valve has got some sort of protective system on it to try to minimize your sutures looping around struts, but it's not perfect.
I always check.
Yeah.
Middle drivers. Ideally, open the right apron, you do that to the corner of each side. Okay, that 305. People, that's now quick. Up by. Just looking at the. It's almost ready. You have a drug sucker somewhere? Yeah, we got it. Where's the drug sucker with the drug sucker? The pepper? Yeah, the other one. The other one? There it is, okay. There it is, another. Best idea ever.
¿Está bien? Ok, gracias. Gracias. No, that's fine. It's not something that really is very good. And there's not a lot of money.
Definitely looks a little on the thin one.
Tables down.
Well, it looks like they've got the mitral valve in and the left atrium closed, and they've now opened up the aorta. Take a look at this terribly calcific bicuspid valve. The aorta looks a little bit thin to me, which is not uncommon, right, with bicuspid valves?
¿Cuánto tiempo desde la canción? Desde la película llevamos en la carrera. 52 minutes. Did I catch you? 52. 52 minutes. You okay? Did I get it, John? No, but did I get it? Sorry about that. Did I catch you? Yeah.
The closer we are, the less chances we are. We got a 23. Sorry about it. That's Robert. That's good. Huh? Much better than the way that it was before. Yeah. It seems like you never done control. It's a little bit like this is gonna like because of the year of the middle of the summer. Otherwise, if you start with the front, they're now we start to work up. I'll be never corner to get some questions about what they want. And then I put the right and then the right. We do the same. Then we'll go to the yeah. You put some tourniquets sometimes in the crunch and style. Then the edge of the order there, and then especially when you find the now the
¿Estás seguro?
No, pero no.
¿No te la ha pasado tráfico antibiótico?
Sí.
Sí, gracias. Hola, ¿me puedes pasar un kilo de enfermera para la zona 2, por favor? A ver. Gracias. ¿Tu computadora de verdad?
Ya les pasamos 30, ¿no?
Ya podemos iniciar.
Sí, adelante.
¿Verdad? ¿Tenemos el recuperador? Sí. ¿Me pueden ayudar con el centro? ¿Con una banda? Gracias. Para taparlo ahí. Bueno, tenemos burbuja. Sí, sí. En disfrutar y 35 y 35. Muchacho. ¿Podemos checar la calle, por favor? Está tirando.
No viví.
Doctor Iván, ya terminé el eco basal, pues se confirma el diagnóstico previo del prolapso del principalmente P1, P2, A1 y hacia 2, esta zona está más principalmente está prolapsada P1, P2, que es lo que ya habíamos visto, hacia A1, A2. Pues la función está leve de la enfermedad y si está dilatado, no tiene otras valvulopatías importantes, también tiene un prolapso de la válvula tricúspide, pero la IT es ligera, como ya se veía en el previo. No sé si requerían algo más de nuestra parte. No. O ya está la salida. Ya está la salida. De acuerdo.
Te queda la sonda, ¿no?
Sí,
Sí,
queda
ahí
acá
está.
todo.
Doctor, ¿pidió ya el parino? Ya. Ok. La pido. No lo había pedido, pero ya paso por el parino. Doctor, paso mi teléfono antes también. Ahorita.
Ahí está. ¿Lo dejo prendido?
Sí,
Estoy alcanzando personal. Sí.
no.
Los que vienen ya de fábrica. También aquel. ¿Serán respiradores de goma? Ok. ¿Puedo tomar la muestra? Sí. Esa es la arteria, ¿verdad? Voy a manipular la línea. Voy a poner un poco. ¿Nos vamos a quedar en normotécnica o bajamos? No, no, no. Gracias. Unos que te digan. No, no, no. Ok. Bueno. Ah, ok. Ya, pues.
Ahorita estoy en colegio. Está, sí, sí, pues 65, había una cosa que está hablando 97. Un poco de side a la derecha. Ahí, gracias. Proceda. Mayo. Sí, sí. Una cosa. Quiere que le pongas a la cánula venosa, que le pongas una extensión para que tenga, o sea, que tenga de plástico, que sea una wire un poco más larga. ¿Tienes? No. Que le pongas un pedazo de plástico a la superior, a las dos, a la superior y la inferior. Sí. Una extensión, bien, extensión pedazo de plástico. Y conectores. Sí, lo que pasa es que las pasa, o sea, tiene que estar más abierta para que pueda separar bien, separadas. Una en medio y una. ¿Tiene que venir? ¿Vas a necesitar un en medio? Sí. Ese no tenemos, sí. Con 30 centímetros, sí, sí.
¿Necesita reductor de un medio tres octavos? No, tres octavos y un medio y medio.
Mi reductor, un reductor
Reductor
y el otro 3 octavos.
Ah, ¿de cuál medio? Está bien.
No tienes un selector.
Un medio, tres octavos, un medio.
Ah, te doy medio 3 octavos.
El de tres octavos, ¿me pasó? Y te lo componemos
Otro igual. ¿Ese qué es? ¿Ya te faltan?
tres octavos, pero ya no. Tres octavos todo. Tres octavos.
Tengo una que es Ayúdame con el ventilador, bajando. Bajo el ventilador. Ah, espera. Ahorita otro, sí. Ya checaste el aliento, ¿verdad?
No, todavía no. Voy a checar. Voy a pasar volumen. Tiene que estar un medio. ¿No? Ya no está mucho. Ya. Este número que me dejan. ¿Sin gradiente? ¿Otro más?
Gracias. Ya lo sabía, qué bueno que- ¿Te dan?
¿Qué?
Yeah, it's okay. And then we can try and sheep in the bottom. Yeah, we can walk. This is just it. Yeah.
Ah.
Yeah. Yeah, yeah, yeah.
Tirando el marcado y no marcado, por favor, Reyes.
Regrésale todo lo que te llegue, ¿eh? ¿Verdad? Eli.
There's no coverage, right? Yeah. That's something. This was.
Yes.
I think it's a little bit.
Well, let me just. I don't know how he put that on. Let me. Okay. Is it okay? Very good. Okay. Okay, be right back. Okay. There's just a little piece of tape right here. A little piece of tape.
Yes.
Thank you. Okay, great. Thank you. Thanks for joining. Thank you. Thank you. Excuse me, everybody, I gotta get right through there for a sec. Thank you. Okay, hi guys. Thanks for doing this. So what we can do, hold on one sec. Yeah, we have to put this down. Okay, then we'll take a towel. A towel. Yeah. Thank you. You put that under here now. Okay. That's good. Okay. That's okay. Now I just see the scissors. Then the black, Mayor, do you have the scissors and the forceps now? Okay. Great. Okay, let me just look in here with you guys real quick.
You want to start the bypass?
Oh, not yet. I like to look at this plane first once without air. Okay, so if you'll just hold this out of the way. No, it made a little hole in the atrium. Maybe we should start it. Okay, we can go on.
Yes.
And we have to get the vacuum on. Wait, this patient has a PFO, right? Yes, we shouldn't put the vacuum on yet. Okay. All right.
El pulmón cuando quedan, sí.
Mhm. All right. That's good. Okay, now we get the cross clamp. Okay, you hooked up the Vanagrade? The cardiac feature? Great. Okay. Okay, the flow down. Okay, back up.
¿Listo?
Empieza la aorta.
Okay. But now they can turn the vacuum on. The vacuum. Oh, I didn't put that silly headlight on and do all that. Okay, I'll have that. Go. Good. Make sure this is working. Okay, good. Great. Great. Now you can just, let's see. You have to figure out how we're gonna put that on and not contaminate everything. But. Yeah, let me just see. Hold on one sec. Mary Jo will help me. Mary Joy, can you hold this one sec? Okay, can you put that on? What? He's got to put that on.
Oh,
The headlight.
oh, okay. Yeah, I'm holding it.
Okay. Yeah. No, it's got to go down. It's okay. Wrap it up. Close it up and then we'll do it. Yeah. I don't want to contaminate anything. Thank you. Okay. Down a little bit. Over now. Yeah. Okay, good. Okay. Thank you. Okay. I'm sorry, tell me everybody's names again.
Ivan.
Javier.
Javier.
Javier and Ivan.
Yes.
Ivan's not a Spanish name.
No, Ivan.
Ivan. Ivan. It's not Ivan. You go by Ivan or Ivan?
Ivan.
Ivan.
Iban en español.
Ivan en español.
Iban en inglés.
You tell me what you're, Ivan. Ivan, tell me about your interests. What are you interested in? What's your main interest in heart surgery? What do you like to do?
Aortic surgery.
Aortic surgery. Good. Okay, so we're gonna get 1,500, right?
Yes.
Or the other one is on the yes and the other. Okay.
Well, thanks for getting this ready, guys. Doing this case with me.
Yeah.
Thank you.
Thank you.
We'll have a good time, I think.
We're waiting for the cardioplegia to go in before placing the retractor.
¿Puedes pedir martillo, por favor? Martillo.
What do they use for this?
Because the
Yes.
diaphragm's warm, and so this keeps the heart cold.
Okay.
Yeah, you'll be surprised. Yeah, the diaphragm gets very warm.
Oh.
Because the diaphragm's 36, the heart should be 15 or 12.
Thank you. So now, worst thing is, see if we can see this PFO. Alrighty, so raise the table now.
¿Podemos subir un poco la mesa, por favor?
Got to bring the table up a lot. Yep, keep coming. Okay. So. See if we can this PFO first. Okay, pick up a sec. Okay, but hold a second. Let's see. You can see it. Another pickup, another pickup. Okay. So there's your PFO here. See that, guys? Here's your PFO right here.
Oh, yeah.
See? So you don't usually you don't have that minority trained to fix that. See?
Yeah.
So you have to help me now, pickups. So you'll hold here like this. Get a forcip and hold there. And you're gonna hold that. And we'll close it up from here right now. And we won't have any blood in our face either. It's just nice. If you just leave it there for a second, they're only gonna take a minute. Okay, hold on a sec, guys. This has to be longer. But this is shorter, okay? Like that. Thank you. And you'll follow. You guys ever done it from this side before like that? You do it like this?
Yeah.
You ever close it from the left side?
No.
It's a good trick.
We used to open the right actually.
I know. I know. You know, if you don't have to open the right, it's good. And then the blood doesn't come in your face while you're doing the mitral. And the key there is if I take the groove back far enough, I can get right into it. As you can see. That works well. So yeah, there's a new trick for you.
Yeah.
Close your PFO from the left side. How long have you worked here?
I'm
About
14 years.
14 years. Good for you. Okay. Now I'll take these two together. Well, I know you guys don't need us for anything, but we appreciate you letting us come and see. It's a nice center. You guys do good work here. How Okay. Good. It's the key part of this retractor. See how it opens up like this? It creates a working port. It's the one part of this retractor. Okay, now if we'll just tie this in like this, just for a minute. Yep.
Good.
Thank you. Here we go. All right, so we have a nice view of it. Looks like this. Turn this one on, maybe. Can you turn it
¿Podemos
on?
aspirar el tercero, por favor? Sí.
Yeah. So now, look a second. You can just do a quick look at the valve since people are watching. So here you can see the prolapse. See that, guys? So here's your prolapse. Here, there. And we have good height here. Here's your other side there. Let's see, that's good. Yeah. And then we have this side over here that's going to be normal today. It's almost small. So that's very straightforward.
P2 and P3.
Yeah, it's a big P2. I'll show you the way we like to fix that these days. If you don't hurry, it's going to be over before you get the ice. You're gonna guys are gonna put snaps on it. You can let go of that now and get some snaps. To put snaps on these. You know what we can do is we can put the margarita, we can put the tequila in that in about an hour. We can all have some tequila with the chips of ice. What do you think? I think we earned it today. You're making me thirsty.
Yeah, maybe she'll run the star. We just
What's your name?
Mike.
What is it?
Mike.
Miter? Miter?
Mike.
Mita.
May.
Mita. Yeah. See how old I am and how much help I get?
What?
You see how old I am? She helps me. Because I'm so old that she's like for old surgeons, she just knows what's coming, so I don't have to do anything. So that will go up there, guys, like that. Just work over here for a sec. And the hook a second. So if you're ever doing a mitral hearing, you can see how this is a little bit harder to see. So what we're going to do is use our hook. Let me get a good grasp of tissue. I learned that from Carpentier themselves. See how much leaflet I'm grabbing there?
You see all the angles.
Yeah, so that way I can really get a bite in the fly gun here. So it's pretty weak there. Let's keep going. These things in here for so we can really see. There we go. Here. We can let go of that now. So you have two fins. You guys can let go of this. You don't need to do that. That's just to let the heart relax. Okay. And then you take this one. Down. Pull back there, you can put this one through. Okay. So now you'll take your side, I'll do my side. What we're going to do now is each one of these will go under just a little bit of tension like this. Hold on, let's move this retractor. So we can really see the posterior leaf foot. Okay, so then we'll put all these like this. Yeah, each one of these will help us see what we're going to do next. Good. So let's do this. Okay, so now we have a nice view of the valve. Now, the next step will be to reconstruct the posterior leaf foot. Yeah.
You have some of the, concepts and, because they look like,
Yeah.
that's the question.
Oh, no, that's great. So I'll just explain. So Mark, so I've just we put sutures in. And we're going to pull on these things like so. And now you can see I've got great exposure of the posterior leaflet. And I didn't even, honestly, we never looked at the interior leaflet, but now we've got the ability to do a proper analysis here because it's all posterior leaflet prolapse. And what we have to decide is the shape of resection we're going to do. So here you can see some of the interesting parts of this. So here's the P1 is minuscule, as you can see, it's very tiny. We have a good cord to the beginning of P2 here. Here's the chordal elongation here. No rupture, just elongation. And then over here is the P3, it looks like. And then this is all anterior leaflet here. So this is all anterior leaflet. What we were doing first was we were closing the
P1,
PFO. P1's just short, it's small.
but
You can see, oh no, you can see how tiny it is here. So we have to stay away from that, I think, because that's too small. This side is reasonably good. Even with this distortion of the valve for exposure, we can still learn something with saline. not as much as we'll learn in a few minutes. To see if we can confirm what we saw. That's the prolapse there.
That's how it looks, you know, in the
Yeah, so that's the prolapse. So,
products without a flail.
yeah. So at any rate, we can take this leaflet either way, and that's what we'll decide next. But my bias is to go this way. Here's what we're going to have to eliminate here. So I think the easiest way to fix this is, I'll show you guys. Because we could take this either way. Let's just see. But most of the prolapse is that way. So I think this would be the easiest way to fix this. So the first step is 5A. So we'll remodel the free edge on the side we're going to keep. So that's step one. Is whenever you've got a triple segment valve, I'd like to make it 2. Now you have to follow. And this always have to be under tension. That's it. But basically, if you have any little indentation, it's going to end up on the closure line. Just like this morning, we like to remodel that as a first step. So that's what we've done with just a simple little crowing. Okay, so that should take care of that. Now you need a hook in a sec. Hold on 1 second. Let it down. Pickups. So we're basically going to convert this instead of multi-segments into 2 segments. Now we have this side will be done. And then you can just sort of see the other side, what needs to happen.
Dr. Gillenoff, so he can resect portion of that other, of the P2.
We're trying to cut things short, because we're inside the heart. So now
Reconstruction.
you can't see that very well, but we want to not leave a lot of bone in there. Okay, so now that's done. Now get your hook again. See, now you've got a fairly good surface of coaptation here. It gets to be weirder here, and here's obviously where it's very pathologic. So usually what I like to do now before I get too far is go ahead and try and visualize what you don't want anymore first. And so what I don't want are these, hold that please. You can see how those are the cords that are elongated. Try one more time. Just like this for a second. So they're all going to go. You got to pull and hold. There you go. Like that. Thank you. So before we do the leaflet resection, if we cut that, that generally lets us see everything better. So that was useful. Now on this side, what we've got to do is we've got to figure out where we're going to sew to, because you see it's very hypoplastic here. And so that's not really a good place to sew to. So I think our better place to sew to is over here. Even though that's elongated, that doesn't make any difference to me because we can always use Gore-Tex later. Hold this, please. Now I'll take the scissors, I think. And so this is the area where the chordal elongation is. So we'll start by getting rid of that. You can see all that was that very pathologic. Okay. Now let's look again. Okay, you're going to hold that. We don't want any of these secondary chords. See how matted that is? It's very diseased. So we don't want any of those there. And then that looks much better. This is a good target for height. Scissor a second. So we'll cut this one too. That allows us to trim it like this. Now we're almost good on this side. Now on this side, 11 blade, because we're just visualizing how we're going to put this back together at the same height with no tension. So a tiny detachment here is going to be useful, just like that. And see, now I have this little tip on it, so I want to get rid of that. And then I'll just take the hook one more time. Same maneuver. Whenever you close this, there's usually a pommesherl fan cord here. And so you don't want to leave that. I'm going to show it to you here. See that? So hold this, please. So anytime we remodel a free edge, we're always going underneath the valve. We're trying to create a nice mobile leaflet in the corner here. And we're going to move it over just a little bit. So I don't want it getting retracted. I'm just looking to see if there's anything else. That's margin. I think we got it. Okay. So now you can see all we have left to do is basically line these up till we have a normal leaflet. So we've detached one side. We did not detach the other side. Hold this, please. This is all just stuff in the basal cords that we're not going to use, and it'll help me to see it better if it's not there. And now it's just a matter of remodeling the annual on spot 40.
And you slide the.
Yeah, see, this is the sliding side. This is a non-detachment slide. So usually I'll do the short side first. I don't want to get it too short, but I think one suture is going to be good. So we'll reattach this side like this. Hold that, please. It's important to stretch the annulus on the other side. So we'll get like that and stretch this annulus like this so that we can travel just a little bit. I think that looks pretty good. So just come back to that one more time. I can give you that for a second to hold. Take this one. If you just hold it in the air, that's what I asked you to do. That's right. So we got to pull this up tight. Pull this tight. Yep. There you go. Okay, so that's going to be one side. Short. Yep, thank you. And now you can see you're just visualizing again your residual leaflet. You're just sort of going to be like that and that, right?
Yeah.
So if you see that, then you can see how this side is going to go down like this. It will all come together just fine, I think. So on this side, we can do it a little bit different. This side, we can start from the outside and work our way in. So I'll give you that for a sec. Second. See, I'm verticalizing this side. The other side was a slight, you gotta change, when I hand it to you, keep it on the same side. Thank you. So on this side, we go away from me. I'm also right-handed, so it's a little bit faster. That's right. If I hand it to you the other side, it's because I'm changing directions. So always a little few tries to get used to all of this stuff. That's all. So that will take care of this side. Now we back up in again. What so goes. We'll just take the 5A. I think it's easier to do today. Now we're just going to get the rest of this thing here. Hit this side. But pull them both up. This goes up too. Yeah. Just in your hand. That's it. So we don't snap on that. Put a snap on these please, together. Always have to hold them both up. It's hard, I know, it's hard to ready it up. Okay. And the rest of them we can do quickly. You just put those two on a snap. That's it. After that, it should be very straightforward. Holding them. Let's bring that around too. Okay. Back and I'll cook these. That's okay. That's good. Thank you. Now the needles are off. Pull up gently on that one, please. Okay, and we cut that one. Good. And the last one. Okay, now we have to relax all of these.
All those are very generous teachers.
You think they're
You think-
generous?
Yes, you think.
They're full thickness.
This one.
Let's see, we have to let these down now because we have to drop the back valve back into a position where we can understand what's the residual thing is. So now we'll drop the valve back in the ventricle to get it back into a little on anatomic plane. Okay, thanks for enjoying. Then we'll get the valve on again. So it's a little messy there. We'll have to fix that in a minute. It's not a big deal. So we're getting close. A little messy right here. I'm not quite sure what happened there. So that looks good. Got a little indentation here and this little bit of stuff there. So we'll fix those two things real quick. Those scissors in a second. It's okay, it's just messy. Reach a little bit like that. In the hook. This is just where we've got this little, and we're just so minimal tissue here. So we're just trying to remodel the free edge just a little bit. Let's see if that'll do it. I like that. Thank you. I'm just coming back. Like so, I think. That was a good boy for freedom. And then we need the long axis view up there. The long axis. Probably one more 5. Oh, quiero dar ahorita. Yeah, can you make it move? That's the 4-chamber. That's like the long axis, but okay, there's the remodeled leaflet now. See how nice that looks now? See how symmetric it is? So Mark, we just remodeled the free edge to make it very symmetric. Now you can see how it comes together perfectly. Marking pen. See, it's just using these little sutures to create this coaptation zone like that. And then we can take a 32 or a 30 or something, and we'll see. It's either 30 or 32. So now we'll test it one more time. Yeah, that's what I needed to see. Those are all 4 chambers, but it's okay. So we have a very competent valve. We don't want to mess it up any further. We just make, if we do it right here, we'll be fine. So we'll take one look at the foot and see what this looks like. And you can see that looks pretty good. Yeah, see how much is coapting? Great coaptation. So that's why I said the marking pen helps us understand what size we want to pin. That would obviously be way too small. And so that's where that really, the marking pen helps us get this right. And the 34.
And you take the size from the
anterior
population line
leaflet,
to the
anterior leaflet surface area, and I'm trying to get, I want about that much of the leaflet underneath it when we're done. Well, something like that's going to be good, I think. Again, I don't like this dizzy eye too, but I'm going to try it again. Now there's your. Yeah, we're always between these sizes, and generally speaking, in a case like this, I think it's safer to go up if you want to. I still haven't seen the long axis. Guys, we got to find a long axis view. It is a. Just go to 130 or 140 up there, the degree.
Ya habla de los eco, por favor. Urso.
Yeah. Just put it down right there. How many sutures are there, Mary Joy? A lot or a few? 13. Yeah, enough. Let me just gonna look one more time. Okay, back to this. Then I'll put that third, that's through one more time. Fine. Any luck? Look. Now that's good. Just got to see the 30. We got to go to 140 degrees and just look at the long axis. It's really not complicated. We have to have it somewhere. I hope. Tell me synthesizer one more time. Yeah, we use a 32, okay?
32?
Yeah. Yeah, we've got this nice and cut down, so that's a better size for this. I mean, again, it's one of these ones with the physio too, you gotta know which ring you're talking about. And that ring's got a big saddle. Play this for him, for me, please. Let's run that one. Let me just see the echo images, guys. This is, we gotta get a better system here for this. There's only 3 degrees that we need to look at to do mitral valve repair. Let's see, yeah, turn that on without color. Do you have one without color? Okay. You'll hold for me, please. Can I give you this?
Yes.
I'm gonna put those in because you can't see from this side. I need to put those in across the top. See, then, no, you can't do that from this side because it's not like a replacement. Each one is spaced differently. So you can't see it, so you need to load it forward here. Swing. Yeah, all these features you don't need. Yeah. I never put in a complete ring these days. But it all works. What they're doing. Okay, stop there, please. Thank you. Okay. Put that in this now. Hold that, please. How are you doing? I just wanted to see the long axis if you had one. Hold this, please. It's a little late, but I'm still curious. Get through the green line. Get through the green line. No, no, see, let me show you, teach you something else. No, watch. See the ring, how we invented it? It's just got a little sewing cuff there, so you don't want to go, yeah, that's better. I mean, I'd rather it be 1 millimeter more. Good, okay. So watch, take this. Watch how I do it. I set it up so I take the ring, turn it around, and see how I just get that, see, the sewing cuff part. Okay, thank you. Oh yeah, it's wide open. That's all I needed. Thank you. Yep, great. Good. Here we go. Next. It's fine. Was it, yeah, go ahead and just put it through. Here we go. That's for you. So you have 4 to go. You travel a little more. 4 to go. Yep, that's good. Better. Thank you. That's for you. You to go. Travel. That's good. See that most of the dilatation was on this side of the third. So just in the middle. Yeah, good. Perfect. Thank you. Okay. That's good. See. Good. Then I'll pick one vortex. Hold this like this, please. Right. Okay. Scissor a sec. Hold that please for 1 second. Okay. That's just in case we didn't gauge the height right. We'll have that little suture there just to protect us from too much motion here, and this gets tied right in the airplane hook. Very good. See now it's see how it fills the ring. Everything is the ring is completely inside the or the interleaflet's completely inside the ring. So you're taking advantage of all the coaptation of the posterior leaflet without any compromises. Hold that.
You're the best prognosis.
You bet. I think we're just gonna keep going. How long we've been clamped?
¿Cuánto tiempo vamos?
57 minutes. So it took us about 45, about a minute, it takes about an hour. Yeah, everything. What made this interesting is this little hypoplastic P1. You have to think a little more carefully. And one side is very almost tethered and the other side is very tall. That's why it took some extra time. So hard one to fix with just a triangle. I'd be happy. They taught me how to tie 4 knots when I'm in a hurry, Scarpentier. You know, he tied 4 knots on anything. 4 good knots is better than 6. Here it falls. But I really you can appreciate how symmetric it is. So see the symmetry we have now, look at that. So it might be too tight, let's see.
All the palpation is symmetric.
It looks pretty good, doesn't it? All things being equal, you surely doesn't make your vortex too tight. Then your vortex is just a fraction too tight. All of the ventricle is really extended now. Okay, so I think it just needs to be a touch less tight. I think that looks pretty good. Wait a second. It tends to slide down sometimes, so we just be sure we didn't pull it down too far with that, which we did, I think. One side pull through. One side want to pull through. Oh, that's a shame. Yeah, the Gore-Tex pulled through. All right, no worries. I'll go over it again. The Gore-Tex pulled through inside. I gotta redo that real quick. Well, the first step is to decide if we need it. Let's see. I'll tell you that first because there is like, I'll look again without it. Was it tore one side just a little bit? Let me borrow that tester again. I'm just going to test one more time to see if I need it because I made it tore through one edge. It didn't need it. I was just in case, I was worried about whether we'd have too much tendency for systolic motion, but it looks like it's lined up perfectly. It really was just there for case you needed it. Look at this side one more time. It's this physio too. You just keep press this on and test. That's why I never use it. I'll just be sure we need anything. That also is sorting it out quite a bit. So sometimes you have to do the test without anything in there. See if we can see it now. One last time. Wait. Don't want to do that twice tonight, do we? It's time. That's what I mean by minimal tissue on one side. It's always annoying. But it's just getting stretched out from filling the ventricle.
Oh,
I think it's okay.
the vortex. The vortex.
The water test is very difficult when you've got this silly physio too right now too. I'll tell you right now. So let's look at this side. See how minimal our tissue is here? No tissue. Always trying to build up the tissue. One more of those sutures, I guess. That 5 eyes better. You're constantly trying to borrow tissue from one side when you've got this hypoplastic tendency on the other. This is this free entry modeling that we tend to believe in quite a bit. Or anything we can find good without pointing really, but See if we can increase coaptation here. This one. These little guys are always annoying. You end up in this with minimal tissue on one side. Back. Try that too. Should be getting close. So Ponte only gave one saline score. He just wanted to see symmetry. He didn't care about anything else. There we go. See there? Mm-hmm. Now it's very symmetric. Okay, the hook is set. It's very good. And then when I push in, instead of making the bigger, I'm make it smaller. And the hook. That's what I. Nice. Oh, I need to look at one last thing. And that hook one last thing. Perfect. Okay. Are they warming up? You get a pickup. Hold here, please. Yeah, hold right where I put those sutures. Table. Yeah, and then I'll take the, we're just gonna close it. No, I don't think so. We don't need to, the suture. Table toward me a quick.
¿Cómo dar pega a la derecha?
That'd be good. That's good.
¿Estamos bien?
Pour a little bit there from our retractor. So whenever you see that, you have to do it again. 4-0 you should always close it in 2 layers if you get this. Really, you don't ever have a individual layers. If I ever see that, I just fix it twice. I know my other suture is going to close it again, but I like to make sure. It's just a little bit. Okay, take that off. You have to give me the other one so you have it in your hand. You come back to New York for 3 months, I don't have you in ship shape. We have our trainees sits for about 6 months to really learn every step, and then they get to do stuff at the schools.
How many trainees do you have on that?
Um, we have 2 a year, so 12. Plus a few fellows. Ishmael takes a aortic fellow. Next year, we're gonna have an aortic and a mitral fellow. We do about 1,700 hearts a year. How many mitrals do you guys do here a year? Like how many aortic and how many mitral?
Mitral, like 100?
Yeah. And how about aortic?
Aortic, like 300.
Wow.
300.
That's great. Wow. It's a lot.
Very few coronary. Yes.
Okay, we got
Maybe 100.
We're lucky. How'd you escape that?
Like 20 to 30 aortic dissections.
It's good.
Yes. Acute.
Sure.
So,
Okay, we can put the head down. They can go in Trundellenberg.
le bajas la. Voy a subir la música un poco.
You guys are busy.
Like from the UFO.
We closed it. I got it from the left side. I showed him a new trick. Okay, you need to help me get your foot stuff. Yeah, you notice if you operate with me, you always have to be on your toes. It's good for you guys. You should be getting the scissors in your hands already. Okay. Let's join. I don't want to put too much down. Okay, ventilate. Big breath. The sheet. Big breath. Okay. Out. Mhm. Hold on, please. Take this off and put it on here, please. Put that on here. Is there?
El marcado para marcar. Okay.
Turn this on. Mhm. Okay, ventilate. Take this off, please. I'll leave the facing wire on. Be careful with snap or something. Slow down. The pump down.
Baja el flujo.
Okay, back up.
Descansado. Recupéralo. 81 minutos. ¿Tienes
Yeah, that's good. Yeah, very good. Thank you. Thank you, Doug. Okay, pick up. Ba-da-ba-bum. I think we got a good job. Turn this on.
Podemos subirle al no marcado, al tercero, perdón. Sí, subirlo al tercero.
¿Entra? ¿Pero con el puesto? ¿Quiere con el puesto, Javi?
Sí.
Pues,
¿Sí?
ya. Este por arriba. Este cambia. What's the pressure up there? 13. What's the blood pressure? Gotta get the mean up to 70. Okay, what's the pressure now? Number at 144. 44, the mean has to be about 75, so with the syringe is better. We'll tell them we're gonna reduce the flow a second, the D air.
Yes. Tienes una sola cava, ¿eh? Ah, está bien.
Oh, oh, that's the little thing I did with my force pickups a sec. Remember that? I tore it. Lungs off.
Baja el pulmón, por favor. Vayamos.
Una disección on a 4-0.
No, perdón. Va a cerrar el lado derecho. No, pues.
Amazing how a little tiny hole bleeds like that, isn't it? Yeah. It shows you how a gunshot one kills you. Like bang, you're dead in 2 seconds. We lost our monitor. That's not good timing.
Oh, it's very much. It's the one. It's a. So, yeah.
And today, that looks more like a heart.
Very good. So,
Pretty good. I can't see it very well, but. What do you think, Professor? I can hear. I'm sorry, what? Oh, that's nothing. That'll go away. That's nothing.
yeah, I'm doing the disclosure.
I don't see anything. There's a little thing in the back. Yeah. Thanks. That looks really good to me. And the motion looks okay. Leaflet motion looks good. Yeah, that's a view I like. Yeah, that's just fireflies, right? That's just tiny stuff. It's gonna get better when the ventricle gets better. I think the motion looks good, don't you think?
Huh?
Here, I gotta take this headlight off. Can you guys pop this thing off of me so I can go look at it? Don't worry. You see the ventricles feathered down, it's smoother, but yet all that rough surface has to smooth out. I just wanted, we don't have any prolapse closure line. No, we're gonna do this on the county show as well.
Yeah.
That's why I say we have to pull it off on the consideration of the program. So this is done, what only you do now is go back on, take the crank off the lower tank. Take the lower crank off, and take that crank off, that crank off. Go back on full body gas, now take this screen off. That one, yeah. And what it pushes you, close that up, then clamp the lower one, take that out while you're on top. You can take your teacher while you're filling in the heart, and then you're out.
It's a pleasure.
You help a lot.
Oh, no.
Just having trouble. Okay,
thank you. Permítame.
Thank you.
It's Dr. Moon here. Thanks, everybody, for joining us today. We will plan to see you all again tomorrow morning. We're probably going to start cases about 8 o'clock. We've got 2 cases to get through, and we'll go from there. We have a myectomy, the myectomy we presented this morning, as well as another a root replacement, possibly doing some arch work under circulatory arrest. So thanks again. We'll see you then.
Hola, buenas tardes. Bueno, el día de hoy hemos concluido ya con el programa. El día de mañana vamos a tener 2 casos, una miectomía y una cirugía de ventral a partir de las 8 de la mañana. Los esperamos.